included.
Yes, ma'am.
In the course of discussion, if any one of the panel also, one of the speakers also have something to add, you all are most welcome. A very good afternoon. A very good afternoon to one and all of you in this yet another very interesting ARC webinar on top pearls in cataract surgery. These webinars have been going on for the last couple of years at every fourth Sunday, and of course, to this Sunday was a little delayed program, but an excellent set of videos. And I'm truly indebted to my expert panel and for the wonderful set of speakers who have joined together. And I think we can all look forward to 3 hours of solid learning and newer learning as each video opens up and evolves. We are truly lucky to have with us on the expert panel, Dr. Namrata Sharma, who should be joining in any time now, who's a professor of ophthalmology and a specialist in cataract, cornea, and refractive surgery from All India Institute of Ophthalmology, and is also the most admirable honorary secretary of AIOS, and who has shown true leadership in these very troubled times. Dr. Mahipal Sachdev has been unable to join us because of his commitment in another society. We have with us Dr. Ramurthy, who is the chairman of the Eye Foundation Group of Hospitals, past president of AIOS, and I'm sure we all know he's a great teacher himself, and to have him amidst us is a true pride. Again, it's unfortunate we do not have Dr. Sanjay Gadre with us because he's been ill-disposed health-wise, and I'm sure we at least need to recognize him. He's the chief ophthalmologist and founder of Gadre Eye Center, Rajkot. We have with us Dr. Swapna Nair, who's again a senior consultant cataract and refractive surgery from Sri Netra Eye Hospital, and another amazing dynamic surgeon and yet a beautiful woman. We have with us Dr. Chandrasekhar Vavikar, who's the founder and medical director of the Vavikar Eye Institute at Thane, Mumbai, a leading cataract and refractive surgeons who has many innovative tricks and techniques up his sleeve, and we're lucky to have him as on the expert panel. Co-moderating with me, who needs no introduction, is Dr. Anaga Harur, who is the medical director of the Anil High Hospital from Mumbai, and she's also the member ARC West, and extremely dynamic, versatile surgeon. And of course, we have with us, along with us, Dr. Satyajit Sinha, who is chairman and director of the ABI Hospital based at Patna, and cataract, glaucoma, and refractive surgeon, and again, member ARC East for the 2nd term. So without delay, before we start our first speaker, Dr. Ridhima, to present her video, I think most importantly, before we started off, let's say a kudos to Ridhima, because she tells me that she's a mother of a 1-month-old, and she's here amidst us to present her wonderful video. Hats off to your energies. So before we start with her, let's watch the entire video. before we have our first speaker, I truly want to acknowledge Entoad, who have been our very major support system in sponsoring most of our webinars in the last couple of years, and my gratitude to them. And we have our first speaker, Dr. Ridhima Bhagali, who's a consultant cataract and refractive surgery from MediLaser Pioneer Eye Hospital, Pune, who is going to be showing her first very challenging video. On to you, Dr. Ridhima.
Thank you very much, ma'am. So, good afternoon to respected seniors and friends. Yes, Mr. Anand, I think we can play the video.
This video demonstrates various techniques of managing zonular dehiscence at the time of cataract surgery. In case of a localized, non-progressive, single-quadrant zonular dehiscence, the wound and rhexis are initiated away from the area of dehiscence. A capsular tension ring is placed in the bag after a hydrodissection to provide extra support to the bag at the time of phacoemulsification. The second case is a traumatic mature cataract with 4 clock hours of zonular dehiscence. The rhexis is lost to the periphery and is being completed with the microrhexis forceps. Now a CTR cannot be used in this case. Hence, capsular hooks are being used to stabilize the bag at the time of phacoemulsification. A 3-piece IOL is then chosen for its tensile strength, and the haptic is oriented in the area of zonular dehiscence. The next case shows a 2-quadrant of 5 clock hours of subluxation. Intracameral triamcinolone is used in an attempt to identify any vitreous. The wound is made away from the area of subluxation. After the initial nick, often forceps are required to complete the rhexis. Here, a dialer is being used to provide counter-traction in the absence of zonular support. My plan here is to suture the bag to the sclera in the area of subluxation using a capsular tension segment. After making a scleral pocket in the overlying area, a double-arm tenoproline suture is threaded into the eyelet of the capsular tension segment. Both arms of the tenoproline suture are thus retrieved using the railroading technique under the scleral flap. The capsular tension segment now needs to be placed through the main wound into the bag centered in the area of zonular weakness, such that both its arms are in the bag while the eyelet hooks over the rhexis. Anterior vitrectomy was needed here to clear the vitreous, interfering with proper placement of the CTS. After proper placement of the capsular tension segment with both arms in the bag and hook over the rhexis, both arms of the tenoproline suture are then pulled and tied under the scleral flap and secured. With the bag now sutured to the sclera, phacoemulsification can proceed with careful movements. Direct chop is preferred to minimize stress on the zonules. Tension ring is still required here to equally redistribute the stress of the intact zonules and to center the bag. During irrigation aspiration, the aspiration movements need to be slow and tangential versus perpendicular with the CTR in place. And lastly, the IOL goes directly into the bag without any additional maneuvers to induce zonular stress.
Thank you very much. In the 4 minutes, if somebody could teach entire thing about subluxated cataracts. You have done it all. You showed everything along the way. Now, I would,
Thank you very much.
yeah, very nice videos. I would ask the first question, which I'm going to be asking expert panel. And of course, Ridhima could also put in a word. Dr. Chandrasekhar, I would want to ask you, would you believe that you need to place a CTR every time when there is a iris and a lens coloboma, and when there is not an obvious subluxation seen? And would you ever think there is any validity of suturing the iris coloboma?
Good afternoon, everybody. First of all, very good demo and nice videos. Madam, if the subluxation is less than 2 hours, then I don't think CTR is necessary. But the first case you showed, the subluxation was more than 3 clock hours. In that case, it is better that we put a CTR. And yes. Because the stability, the centration of the lens will definitely matter.
Yes, there could be an asymmetric back contracture, and placing a CTR, I think, is a relevant step to go. Yes.
Correct. What are the second question?
Whether would you ever think of suturing the iris coloboma?
Iris coloboma, it depends on the patient profile, basically. It is very difficult to give simple answer, but in principle, yes, I would like to suture iris coloboma to give very good, better quality of vision to the patient.
Dr. Swapna, with the patient who's already visually adapted to that iris coloboma from childhood, would you actually feel the need to suture the iris coloboma? Your thoughts, Ramuti's thoughts?
Yeah, that's the point. Basically, the patient is adapted to that amount of light reaching the eye. And secondly, sometimes the coloboma is very U-shaped. And it's very hard to bring the ends of the coloboma together to form a proper pupil. And sometimes there's cheese wiring of the sutures as well. If you attempt to do that, maybe you can put something very near the root if you want to, have a properly formed pupil. Or sometimes you can keep an iris segment also. So in many cases of coloboma which are large, and you want to reduce the photophobia the patient may have, because even if they adapted, sometimes they keep their eyes very closed when they are exposed to light. So to sort of relieve it to some extent, you can keep iris segments also, which will prevent too much light entering the eye. But if it's a small coloboma and the patient is used to it, no.
Hello, madam. Hello.
Yeah. Yes.
Can I add a few points here?
Yes.
Actually, the questions you asked were really fantastic concerning the zonular dialysis and zonular weakness. Coloboma being a non-progressive zonulopathy, and if the zonular defect, as Vavikar sir rightly said, if it is less than 2 clock hours, there is no need of CTR as such or capsular supporting devices, provided you put a 3-piece IOL supporting that zonular defect. That is one. And another I would like to highlight here is, though the patients are adapted to that particular light things with the colobomas in childhood, but after the surgery, that portion becomes little fibrosed and opaque, and diffraction of the light happens because of all those opacifications. So it is better, always better to try and suture coloboma defect if patient is willing to close that and is willing to pay for.
The other question
I would beg to differ here for a simple reason, like especially if you're doing, I have seen patients in whom I have not put a CTR, and I've seen them 10 years later on with the entire IOL back complex going down.
Yes.
So it's always better to have a CTR in place in even the slightest doubt that you have some kind of a zonular laxity, whether it's a posterior zonules or the anterior zonules, and it's a safeguard for your future. It's not about the present.
Yes. The other question which I have, which I would ask Ramuti to take, is in that particular case where she had a rhexis tear, I think CTR cannot be placed, but a CTS could have been placed. But again, probably because this is a non-progressive kind of a scenario, she decided to just place the the haptic of the IOL itself to support that area of zonular weakness. Your thoughts, Dr. Ramurthy?
Sorry, I didn't notice a rhexis tear. I mean, where was this rhexis tear?
Ma'am, sir, the intermittent cataract, the rhexis ran away to the periphery, 180 degrees opposite to the area of the dehiscence.
Second
The
case.
rhexis ran off.
Okay. Just some thoughts. One thing is, I don't think it's necessary to suture up a congenital coloboma. First of all, it's quite challenging. The patient has lived with a clear lens and has well adapted. And even if it gets fibrous, that's going to only block the light at the capsular area. So generally, we have not been suturing for years, and we have not heard any problems with that. And I would tend to agree that whenever you suspect zonular weakness, go ahead and put a CTR. But the timing of putting in the CTR, for example, the first case, immediately after you made the capsulorhexis in a fairly stable bag, you put the CTR. I think we all know that the difficulties once you have the CTR in place. So I'd have gone ahead and done a gentle phacoemulsification. And I'm sure with that stable bag, the entire process could have been done. And just before putting in the intraocular lens, might have placed the CTR more for dealing with any future chances of the zonular weakness progressing, and which usually doesn't happen with a coloboma. And second thing is, as far as the second case is concerned, the intraocular lens, first of all very beautifully done surgeries, kudos to you. And second case, I would feel that, it's not just positioning the haptics in the area of the zonular weakness, but nowadays the present day concept is to go ahead and place the haptics in the capsular bag and create a reverse optic capture. And if you have the optics in front of the rhexis margin, that gives you extreme stability. And we have started doing that, and it seems to work quite well. And your last case was, what was that?
Yes, there's a CTS.
The CTS again, I would feel that the CTS is for prolonged support for the capsular bag in the future. And in that case, what I would have done is to go on ahead, and you again did it beautifully, used a couple of capsular hooks to support the capsular bag, completed the phacoemulsification, because during the phacoemulsification, you need the anterior support. And subsequently, once the lens matter is out, we placed a IMH segment and the endocapsular ring to tether the capsular bag onto the sclera, and also give circumferential support. So maybe it's just the timing of placement where I would have slightly differed, but otherwise I think you did everything very well.
Yeah, that
Thank
was
you very much, sir,
which I was. Yeah, no,
in the second case, there was something a bit off that I noticed, because your rhexis extended in the direction opposite to the point of dehiscence, and when you kept the haptic against the dehisced area, I am sure the other haptic would have been in the region of the capsular runoff, which is a dangerous situation. So, like sir mentioned, I think you should have kept it at the opposite direction.
No, just one more thing, ma'am. I think maybe in these subluxated cataracts, this is one indication where flax probably gives a very good centered rhexis, and if you can center it on the scan capsule, it works well to those people who have access. But even in pediatric cases or here, because mostly the rhexis is the most critical part in this, so we cannot, most important part. So if at all you think of flax, I think this is one indication where it really is good, especially.
True.
This is where we don't want a runoff like this.
Would before I go on to our next speaker, would all of you feel that a CTS should be placed in the end? We could use capsular hooks, do the surgery, and then place a CTS?
Yes,
capsular hooks, first capsular hooks, and then CTS. Yeah, of course. We need anterior support, as sir has rightly said.
Yes. Thank you very much, Ridhima.
The surgery easier also. I couldn't have maneuvered a CTS inside with the whole nucleus inside. She did it beautifully. I mean, so we must appreciate that.
The technique of doing phacoemulsification was perfect because he was withdrawing the nucleus and then chopping. All the forces were acting towards the tip and then on the zonules. The zonular stress was least.
Very good.
That was a beautiful.
Yeah, hats off to you, Ridhima. If you could continue to be present on and off and watch the other things, it's a learning actually.
Yes, thank you very much.
We shall now go on to our second speaker, Dr. Varun Kharbanda, who is a consultant of Nazareth Hospital, Jeevan Nidhi Eye Clinic, and Mahesh Netralaya. I really wanted to know how he is there in all the three places from Allahabad. And he has another very interesting video to show. On to you, Dr. Varun.
Thank you, Chitra ma'am. Well, Allahabad is a small place. We take about 5 minutes to get from one place to another, so I can manage. It's an honor being amongst this August gathering. After seeing Ridhima's cases, she is my senior from Narayana, and she's always been an amazing surgeon. I've learned so much from her. My surgery is going to be a little bit of a dampener. My surgery is also about a zonular dialysis. I'm just going to start sharing my screen. It was basically aimed at the younger generation to kind of show them the mistakes that one makes while doing surgeries and how to mend them. All of my seniors here, probably it's a everyday thing for you all, but I'll still try and make it interesting. So this was a case of a young patient. A panoptics IOL was planned with an OCCI at 0-180 axis because he had about 0.75 diopter of astigmatism. Everything was going well, but as soon as I started the rhexis, you will notice that the rhexis is probably smaller than the ideal size. We being young surgeons in private practice, we tend to sometimes overcorrect and overdo in premium patients. However, the rest of the steps of the surgery went off uneventful. This is my technique of handling soft cataracts. I dissect, delineate, I make sure I rotate it nicely, and then I do a modified chop where I basically separate the endonucleus first. The delineation, dissection, and rotation actually makes it very easy to eat the epinucleus in the end for me, because that is something everyone struggles in the beginning, especially in soft cataracts. So we can see here that the small rhexis did not really hinder the phaco. It went off uneventfully. And the epinucleus also came out rather easily. So this is when you start feeling good about the surgery and you're like, the major part is over. I paused it here because I want to bring everyone's attention to the top right-hand corner of the eye, where we can see a little bit of a reflection of the phaco drape. Now, I did not realize it then, but I end up pulling the capsular bag right at the beginning. I've slowed it down so that everyone can appreciate that. This is where I pull the bag. However, when I was doing the surgery, it did not occur to me because I just kept thinking that this is a reflection of the drape. I continue the same side and I end up putting a little more of the bag towards the end. Unfortunately, even then I did not realize. Only when I switched sides did I see the capsule rolling up. And now I have realized that something wrong has happened. I can see the capsule rolling up at between 12 o'clock and 1 o'clock. I could make out that there was no vitreous loss because the pupil and the bag were undisturbed. So I decided to finish the irrigation aspiration. And again, for all the young surgeons, never take out the irrigation without injecting some visco in case of rend or a dialysis. This being a panoptics patient puts an additional pressure on you when you're in a standalone private practice. But because I was pretty sure that the dialysis is not more than 2.5 clock hours, and I had access to a CTR, I decided to go ahead. So while they were getting the CTR, I decided to do the OCCI. And this is pretty much routine, like how Ridhima had explained. I used the McPherson to introduce the CTR in the AC. And then I use the microrhexis forceps to place the CTR. I'm just going to run it up a little bit. That's it. And thankfully, everything went well. The lens was nicely centered. The patient was, I think, 6 parts in N6 on day 1, but he's happy he got the other eye done as well. That's something I always tell myself, the patient comes back for the other eye, and that means you did a good job. Yeah, that's about it, ma'am.
Yeah. Thank you very much, Dr. Varun. That was a nice teaching video. Now, I just want, before we go on to the actuals of the surgery, I just wanted to ask Dr. Vavikar, now, when would you look at doing a toric multifocal IOL, so a small amount of astigmatism in the eye? Would you have a lower limit at which you would start, Dr. Vavikar?
Yes, if the post-operative astigmatism is going to be one diopter, that is the time I start thinking of at least one diopter. That is the time I start thinking of toric monofocal or multifocal.
Isn't it against the rule or with the rule? I think if it's against the rule, I would look at even smaller amount of astigmatism to start off with. If it is with the rule for one, yes, I would wait.
Yeah, madam, actually what happens is that not every patient progresses in the against the rule manner with age. There are a lot of patients who don't progress at all. If you see the percentage, it is very difficult to decide what to do. We had developed a nomogram, like for every 10 years, the astigmatism increases by 0.34, but it does not work that way. So it is correct to, undercorrect ATR, that's all. But I would still stick to one diopter astigmatism.
One diopter is what we also generally were taught.
What is important is that, second post-op day, if the patient is 6'6", patient is happy. After 10-15 years, he develops slight astigmatism. It is pardonable.
Swapna, what are your thoughts about this, so much of hydrodelineation in a routine Phaco case? Besides the pros, which Dr. Varun was trying to say, are there any cons to doing multiple hydrodelineation in a soft cataract?
Rather than that, because there's already a pre-existing zonular dialysis, I would be a bit wary of using the amount of fluid inside.
This was intraoperative, sorry to interrupt.
Oh, okay. So it happened only because you pulled the capsule?
Yes, that's what I was trying to show.
Yeah, fine. Then it's okay. But another way of handling the soft cataract could be to do, I don't quite understand why do you want to leave the epinucleus back? Because if you do a good hydrodissection, you will be able to, actually roll out the entire soft cataract. And then you barely need vacuum to...
I would be happy to explain, ma'am, if given some time. So this is not an NS1 or NS1 to 2, ma'am. Generally, I use it for NS2 and above. When we started off in private practice,
then it's not a soft cataract.
Yeah, so when we started off in private practice, I'm sure others have also felt, because I was training a lot of fellows at Narayana, the eating up of the epinucleus at the end of the surgery sometimes becomes a bit of an issue. And what I realized was going back to the basics and rotating the nucleus after dissection and delineation made it really easy for especially the younger surgeons or the surgeons who are starting off to clean the epinucleus at the end. And the delineation gave them a little bit of a safety net. Obviously, people like you, Chitra ma'am, and the others here, delineation and dissection doesn't really make much of a difference. But this was more aimed at people who are starting out in their career because it makes it slightly safer. Although slightly more cumbersome and longer, I agree, but it makes it slightly safer and slightly more convenient.
This would have been an excellent method for a posterior polar cataract.
Yes.
Is what came to my mind when you were doing that.
Yeah, but I wouldn't rotate a PPC.
Yeah.
The inner nucleus you can rotate.
Yeah, of course, once you show.
The only other thing is you should have, showed everything very well. You should have enlarged your small rhexis. It was just a little too small. After the IOL implant, you could have enlarged it. One question to Dr. Ramurthy is, supposing because of the dialysis, if it had been a little more, a trifocal has not been, a premium IOL has not been placed. So, but it has already, what would you do for the multifocality in this kind of a situation? Would you think of doing a piggyback IOL or would you think of a monovision in such a situation? Here, the area of dialysis was small. If it were a little larger.
You mean to say if we were forced to place a monofocal lens?
Yeah, yes. Yeah,
maybe I would just place a monofocal lens and counsel the patient as to what happened and make him accept the fact that he has to live with monofocality. But if it's a multifocal is already there in the other eye and insists on something, a piggyback lens later on is an option. And as you know, we always have this, as of now, we are having it, 3-piece multifocal intraocular lenses also in stock with us. And in case the capsulorhexis is intact, there are instances when we have gone ahead and done placed the lens in the sulcus and created an optic capture. but these lenses are no longer manufactured. So once we run out of stock, it's going to be a problem. I just want to add a word about this toric component that you brought in earlier. I think it's not just the shift of astigmatism that takes place over time. It's also the fact that 0.75 diopters of against the rule astigmatism is quite significant with a trifocal lens. And usually what we do here is our go-to formula is not Barrett Universal 2, but it's Barrett Toric calculator. So whether we are using a Lenstar or a IOL Master 700 or a Tommy, we always put the patient first on a Barrett Toric calculator. And depending upon the axis of astigmatism, very often you would find that with the 0.75 diopters of astigmatism, it might indicate a T3 or so. And in those cases, we'll go ahead and put a toric multifocal. Now we believe that the 2.2 or 2.4 millimeter incision that you made, the centroid value of the astigmatism is created is just about 0.1 diopters. And OCCI, I don't think when you don't introduce any instruments, anything, it's so easy to do it. So we were doing it, but it hardly has any impact on the cylindrical component. So apart from the use of the panoptic, this is a case where I would definitely, with against the rule astigmatism, put the patient on the calculator, and if a T3 or so is indicated, go ahead and use that. If it's not the absolute number of the astigmatism, but it's also the axis which matters.
Yes, very true. And Anaga, if you have anything to ask, should I go on?
I was about to say the same thing, that I think instead of, and one diopter in today's date is really significant. So I would not even wait for one diopter.
It was 0.75, ma'am.
Yes,
0.75. Yes, no, but even if it is 0.75, you put it on the Barrett Toric calculator or on the Verion, whichever you have. And if it is showing a Toric T2 or T3, we have to
implant.
Especially if it's a multifocal.
Multifocal, yes.
Can I add one point?
Yes, Dr. Bhavika.
Dr. Kharbanda, while taking the cortex, once I purchase it in the eye cannula, I would move side to side and then pull it radially. That will decrease the chances of, it will loosen the cortex and it will decrease the chances of this accidental zonular dialysis.
Point noted, sir.
Yes.
I have a point to make. So many a times, anatomically, if you see the zonules, so you have anterior zonules, you have posterior zonules, and you have equatorial zonules. So there are these few patients who actually have the equatorial zonules which are weak. And whenever you're going there, you'll actually hold the equator and it will come into the bag itself. And these probably are the patients whom you should not kick yourself over because they have a pre-existing equatorial dehiscence. And these are the patients in whom I would definitely go ahead and put in a CTR.
Yes.
So I don't think probably it was an accidental thing or a purposeful thing or intraoperative for that matter. It was a pre-existing thing because the rest of the places wherein you did the IA, it did not come in that easily. So there probably was a pre-existing equatorial dehiscence, and that was allowing the back to come into your aspiration port.
Probably.
Arun, one more point. Your magnification was too low, I think. Was it a recording magnification? Or
it was the recording magnification, sir. I have
recording
a remedial system. It records on a
So your microscope magnification was a little bigger.
Higher, sir. Yes.
Higher, yeah.
Because
Thank you very
any
much.
higher,
the problem was a reflection of the drape. That was a problem.
Sir.
You could not recognize.
That is what I considered, but after hearing Dr. Abhijit's explanation, I want to believe that more than the fact that it was.
No,
Nothing could ever go wrong. Thank you very much. We shall now go on to our next speaker, Dr. Shail Vasavda, who again needs no introduction, who's a consultant cataract and refractive surgery from Raghudeep Eye Hospital and has had innumerable awards and accolades at a very, very young age. And I'm sure we're going to look forward to seeing another very impressive video. On to you, Dr. Shail.
Thank you very much, ma'am. Like in all of the cases shown previously, sometimes you start up with everything going on perfectly, but it doesn't end up well. So this was a posterior polar, long-standing posterior polar, and we prefer doing the femto delineation in this, where we like to divide it. It's like multiple hydrodelineation, except for the fact that you don't require any fluid to be injected. And we try and remove each epinuclear layer from the support of the other. And when the final epinucleus is being removed, we don't completely remove it. We just create a communication so that now some fluid will trickle in, and that will make sure that the intralenticular pressure doesn't rise. I think bimanual irrigation aspiration is of utmost importance in such situations, and never allow the chamber to collapse. And we thought we have done an excellent job. But there's no dehiscence that has been created, and all is well that ends well. The next cases started to be prepared. But notice here that as soon as I'm trying to inject, I generally do a wound assisted through 2.2. I'm being a little bit more casual here. The eyeball is already rotating on the other side, and I'm not using my left hand enough to pull it back. And that made this the angulation of the engagement in the wound a little bit different. So it sort of lifted up rather than staying down. And so I'm struggling to actually inject it through it, and eventually it snapped. Now, any posterior polar, however much you have been careful, this capsule is very fragile. And that was my main worry, that this slight snap may have actually, created something in the posterior capsule. So I didn't want to take any sort of chance. So first injecting dispersive viscoelastic. And then I didn't want to manipulate or push or pull too much on this IOL, because I thought doing that may cause more harm. So I just extended the incision a little bit more, and while trying to actually manipulate it, then I realized this huge defect that has already been created. So now I'm in a little bit of a fix. Almost the entire IOL, except for the trailing haptic single piece, is now inside the anterior chamber. I have an intact anterior capsulorhexis, but I have this large posterior capsular dehiscence, which I've created due to these maneuvers. So first thing is not to panic. I again go below the IOL and inject dispersive viscoelastic, and I thought, let me try and convert these margins of this tear into a strong margin. So from one end, I've been able to convert it, going below the IOL. But I could feel that since I've enlarged the incision, there may be prolapse of the vitreous that may come due to this large chamber. So first I sutured the wound, and I created a pars plana entry so that whatever vitreous that will be there, I will need to tackle it from there. So from the other side, going again below the IOL, I've been first now able to convert this into a strong posterior capsulorhexis margin. Then injecting triamcinolone, obviously there was vitreous that was coming out through there. So with pars plana, what I'm trying to do is I'm trying to sever the connection from the posterior to the anterior segment, which you'll notice here very shortly, that once the vitreous is cleared and the connection is severed, you will start seeing this nick of vitreous now floating. So once you see that start floating here, that means that the connection from the posterior part is removed. And then that means you can remove this from the front part, because now it's not going to keep coming. The vitreous is not going to keep coming back. So finally, I've sort of converted this into a strong rhexis margin and have managed to remove the vitreous. I want to make sure that I see everything that I'm going to be doing, because this is a single piece IOL. So I want to be extremely sure that when I dial this lens in, not only do I not put much stress, but also make sure that the optic haptic junction goes inside the capsular bag. Initially, I thought it did go, but then on retracting the iris, I realized it's still not there. So it's very important to keep seeing and making sure that the optic haptic junction in this case is absolutely inside the bag, because you cannot leave a haptic of a single piece in the sulcus. So once again, making sure that the anterior capsulorhexis is covering all around the optic. Once that is done, we once again make sure that during this manipulation, there was no form of any vitreous further disturbance that was created. And this little strand that was stuck in the incision comes out, because there is no, connection now with the posterior segment. So this is, the end result of the surgery, where fortunately the single piece has been able to be put inside the capsular bag. Always make sure that even in the end, you do not let the chamber shallow, and hydrate all the incisions before you leave out the irrigation cannula. And this is the patient doing quite well post-operatively. So every step is equally important in posterior polar. It's never over until it's over in a polar, and even the slightest error, even while just injecting the IOL, can lead to a disaster. it's always a good idea to convert your tear into a capsulorhexis. Even if you do not place IOL in the bag, it's always a good practice to start doing to try and convert it into a PCCC. And I think in such situations, definitely pars plana form of vitrectomy helps so that there is no further prolapse of the vitreous that keeps coming up. Thank you so much for the patient listening.
Thank you very much, Shell. That was a wonderful, wonderful video. And actually, incidentally, I had seen your earlier video. I had not seen this video which you had sent day before. But there was nothing more to what he could have done. The way he has kept even the haptic outside, he sutured it so that there is no iris AC shallowing, and how he has done a PCC, and how he did the pars plana vitrectomy so that there was no gush of vitreous coming forward to enlarge the area. But supposing it was a little in the sub-incisional area, even though it was nearly there and you did manage to make a PCC, but with the haptic IOL mostly inside, and if you were not able to convert it into a PCC, in that kind of a theoretical situation, Swapna, can you tell me how this could have been handled?
In this particular situation, I thought initially there was no vitreous because you could see the margins of the tear curled up well. It was not stretched out like it would be when there's vitreous prolapse into the pupillary area or the chamber. So I thought because 3/4 of the IOL was inside, more than that rather, maybe a gentle maneuvering into the remaining space where the with the haptics, well away from the area of dehiscence, I should have kept the IOL there. Then when you aspirate, it should have been minimal aspiration, with low dynamics and all that. So that could have settled, I guess, the entire situation. I mean, he knows best because he was in it.
That could have been risky.
Yeah. Yes.
That could have been a risky because it's a one-piece IOL, and extension of that PCR would have been a possibility. The only option I could thought is remove that lens and place a 3-piece IOL with the optic capsule.
If you put viscoat in the region of the PCR, it keeps the vitreous away enough for you to, manipulate a lens which is already inside the anterior chamber and tug it into the fornices, the haptics.
Yes,
it was only the question of dialing that last haptic,
the inside.
Pulling haptic inside, yes.
Yes.
Just one thing I was thinking, the trigger of all this was the smaller wound, right?
Yes.
So that brings us to the question that this is one of the fallouts of the 2.2. So what I was trying to think is, if this can happen in this case, so even in a routine case, I've seen many times a wound assisted, the wound is not really very good and nice at the end when you're trying to actually push the injector through it. So do you all actually feel that in all these cases, it is better to go in with a 2.2, or it's best to have a clean 2.4 or a 2.6 or 2.8, which would probably reduce the astigmatism and reduce such complications?
Yes,
I absolutely agree with Anagra in the sense that, years together we are doing 2.2. Now we are, as a standard, we have shifted over to 2.4. So less of distortion of the wound and it's much more easier. And especially in a posterior polar cataract situation, sometimes, this push type injectors have a more explosive release. And if you have a screw type, it might be a more controlled release that might happen. But anyway, Shal, good that you showed this video. I always thought you never have complications. Good you created one like a novice, but managed it like an expert.
I think can I give my bit here?
My comment is, the sense that, I think it was halfway stuck there. So instead of pushing this lens, I have also landed in these situations, and I often tend to bring the lens out rather than trying to stress the capsule and then reload the lens and maybe slightly enlarge the incision and then doing it in a more controlled manner. That works out, especially in a PPC where you know that the capsule is likely to be a little friable and easy to give. Trying to maneuver it in is not a good idea. And again, making the incision larger with the knife, with the lens stuck there, and your knife that you introduced was cutting on both sides. And I could see it leaving a mark on the lens also. So I would not have done that with the lens stuck there. And maybe I would have tried to maneuver the lens out of the back, out of the incision, enlarge the incision slightly, reloaded it and put the lens back. But
And
once you were in a
Exactly.
mess, you came out like a master.
yeah, and you should also inject viscoelastic to the side port before pulling out that lens, because there could be some kind of a AC shallowing when you are pulling it out. Supposing the scenario was even more difficult, like there was epinucleus also sitting in the bag, and when we have had a PCR, so how would you, it's only epinucleus, would you look at doing a visco dissection at this point of time with an open PC? Dr. Vavikar, your thought? That's a theoretical situation, because Shell's video did not leave too much for discussion. So I'm asking.
Yes, excellent video. I would definitely think of visco dissection, but before that, I will clear off any vitreous is there in the bag or anterior chamber. And in a PCCC, in a posterior polar cataract, it is not all that easy to convert to complete a posterior capsulorhexis, because the cut is oblong rather than a punched out lesion. But if there is no vitreous, then visco dissection is definitely one of the easiest maneuvers to do. Safest, not easiest.
Would you want to do femto, on those of you who are on the femto platform, any PPC you see, would you strongly advise a femto laser procedure only, or you just put it across to the patient and leave it at that? Dr. Swapna?
Yeah, I mean, we were doing PPCs before femto was around. The femto definitely helps.
Yeah.
But yeah, I would tell them that could be safer with a femto, but maybe not always insist on it.
Yeah.
It would depend on the grade of the cataract, actually. If it's a harder cataract, I would insist on it. If it's a softer cataract, I wouldn't insist on the PPC going in for a femto.
Dr. Ramurthy, would you comment on doing a reverse optic capture in these, not in that particular case, in a case of small PCR in a PPC?
Yeah, I mean, in case like he managed to do it, you have a very strong, nice posterior capsulorhexis and adequate anterior vitrectomy has been done. There is enough support. You can place the lens in the bag itself. But otherwise, the possibility if there is not enough support, then you can have the haptics inside, and through the side port using a something like an iris spatula, you can gently maneuver the optics out of the bag. The haptics stay inside and the optics get caught in the rhexis margin. I think one of the major advantages of using a femto, apart from the nucleus delineation, is that you have a perfect well-sized rhexis. And as we know in this PPC, we aim at a 4.8, 4.9. So when you end up in a situation like this, whether it is reverse optic capture or conventional optic capture, you are able to do it much more easily.
We shall now go on. Thanks a lot. Thanks a lot, Shai. We shall go on to our next presenter, Dr. Abhijit Desai, who is again a practitioner, a very popular practitioner from Mumbai, from Soham Eye Care Center, and a very versatile surgeon. And let us see how he does his 4-minute video. On to you, Dr. Abhijit.
Thank you, ma'am. So this is about IOL exchange, which I had scheduled. We had operated his other eye, and which came up to 6.6 with the Clarion, and the left eye was unfortunately operated somewhere else 3 years back and had an error of plus 3.25. Patient had a lot of anisometropia and issues, so finally we advised him an IOL exchange. Now this is a dispersive OVD which I am using it to open the bag, but the bag doesn't open in all places because it's nearly 3 years old, and it's with a hydrophobic 3-piece IOL. So there are areas of fibrosis which I'm separating out with a blunt iris appositor. So those are the areas which need to be very clearly opened up, because otherwise we'll end up with a zonular dialysis in these kind of cases. We had planned with a 2.8 incision because of the astigmatism, and we plan it on the Varion, of course, and that's how we would decrease the amount of post-op astigmatism that the patient would have. Here I'm trying to rotate the IOL out of the bag, but unfortunately the IOL haptics are really stuck in the bag. There's a lot of fibrosis in the IOL in the bag, and it's making my life a bit miserable. So even though I'm trying all maneuvers, it refuses to come out. So I'm using a Sinskey hook to get the entire optic out of the bag. Even that's causing a stretch on the bag there. Now, part of the optic is actually out, and that probably does not augur well when you are trying to rotate the IOL. So I put the optic back in again and then try to dial the lens towards the wound. Still, it's going to be difficult getting the entire haptic out. So what I do here is I just prolapse a part of it out of the bag and then cut off the haptic here. Once one haptic is out, it's easy to get the entire IOL out of the bag here. I'm using an IOL grasping forceps out here to hold the IOL and pull it out of the bag completely. Now here I'm trying to use a specially made scissor which I can introduce to a 2.2 for cutting the IOL, but unfortunately these scissors are very delicate, so many a times they do have a malfunction. So it's always better to have another scissor in hand to cut these things. So I use a dispersive viscoelastic again, use a Osher's vertical cutting scissor, IOL cutting scissor, and I bisect my IOL. Again, the grasping forceps many a times get stuck with the IOL because they are a bit wider than the opening of the jaws. So it's good to use the Sinskey hook to remove the stuck part out there. And then you can always put the IOL in the bag. A good idea out here is to do a very precise cortical wash and capsular polishing, so that all the Elchnick pearls and the rest of the after cataract which is developed over a period of time come off, and that gives a good vision. I'm just showing this video also because this is an alternative technique of removing the IOL. So this is, I think, I had seen it demonstrated by Dr. Arup Bhaumik from Calcutta, if I'm not mistaken. And he uses this cartridge from the Alcon. He opens it up with a blade and uses this IOL snare to remove the IOL out of the bag. And there are multiple things which have been developed over a period of time. You can use the IOL grasping forceps through the same kind of a cartridge to remove the IOLs, and many other techniques. Like if I'm planning a toric IOL, I would do a quadrisection or a trisection of the same IOL using a very good dispersive viscoelastic. Thank you.
Thank you, Dr. Abhijit. That was a wonderful demonstration, and also the last bit. So let's just look at some questions related to IOL exchange. I would want us all to know that the challenge with getting the IOLs out are more with the hydrophobic platform than the hydrophilic, because there's more adhesion which happens in the hydrophobic platform. But residual anisometropia of 3.25 diopters, I would want Dr. Swapna to comment on this. Would you consider primarily a piggy bag IOL, or would you look at an IOL exchange, seeing the difficulty which she had removing it?
Why not do a laser?
Huh?
It's a hyperopic patient.
Plus 3.25 hypero.
Doesn't matter.
Doesn't matter.
Doesn't matter. You can easily do laser. I mean, whichever form you want to do it, femto, trans, PRK, or suppose you don't want to apply pressure, then do PRK. But I think I'd rather go for an extraocular procedure for such a small amount of residual refractive error. Now, in case it were larger, then an IOL exchange or a piggyback IOL. But in an IOL exchange, I'd always check the specular first. It is very, very important, because once that is on the southern side, it's a bad prospect for the patient. Secondly, if a haptic is not coming out, I'll cut that haptic and leave it there. I don't want the haptic, and leaving it there, if it's not loose, is not a bad prospect at all. It will stay there with the new IOL and nothing's going to happen, especially if it's fibrosed.
I mean, those are the points basically. For piggyback IOL, then yeah, it's much smoother, but always for a much larger residual error rather than this much.
Yes, Dr. Ramurthy.
I would go for it. I don't know. Abhijit is a great surgeon and a good friend, and he did the surgery beautifully. But then there's been a lot of zonular damage, which maybe the bag remain stable on the table. But if the patient has another 25 years to live, this entire back complex can drop off. So I would feel that putting back, especially when it's a plus 3.25 diopters, I'd go ahead and do a piggyback lenses. Now, Indian piggyback lenses are also available at a fairly reasonably priced, and just into 1.5 and put the lens, and first day the patient is quite happy. If it was a minus 3.25, I'd go ahead and do a laser vision correction. For hyperopia, maybe up to 1.5 to diopters, I'll do it on the cornea, but otherwise a piggyback lens. And I think that would have made the surgery much simpler, especially when it's a hydrophobic lens which has been there for 3 years. And if it had been a recent thing, 6 weeks, 4 weeks, and we realized that it is a biometry miscalculation, then getting this lens out is much more easier. But as if at all we had to do a exchange for some other reason, and it was a hydrophobic acrylic lens, as Swapna said, I would cut the optic haptic junction, leave the haptic inside, and just bring the optic outside. And especially with a 3-piece lens, the space that is occupied by the haptics is very small.
Dr. Vavikar, would you like to comment about IOL exchange for a 3-piece versus a single-piece haptic, single-piece lens?
I didn't get the question.
No, if you have decided to do an IOL exchange, the tips for the audience, what are the challenges in cutting a single-piece IOL versus a 3-piece? Do you feel there's anything extra to add here?
No, I think Dr. Ramurthy has covered all the points. Basically, if it is myopia, piggyback is the first thing which comes to mind, because if it is hypermetropia, and the IOL was very well centered in the back. And if it was myopia, probably either piggyback or LASIK.
Dr. Abhijit, if it had been a single piece in the bag, would you feel there would have been a little more of a challenge than the ability you were able to cut the haptic and take the optic out? And
I don't think so, because the space out there is always there. So when you're pushing in a nice dispersive viscoelastic and using blunt instruments to dissect out the bag, it's pretty easy, in fact, for a single piece to come out compared to a 3-piece.
I would slightly differ on that, in the sense that, sorry, please go ahead.
No, sir. Please go ahead.
No, the haptics of the, just like the capsulorhexis margin gets stuck on the optic, the single piece haptics is also made up of the same hydrophobic acrylic material. And the addition to that is much stronger than the PMMA haptics of the 3-piece lens. Another aspect is, I think you most often use Alcon lenses. They have that bulbous tip, and that's where the addition is most stronger. And sometimes it's very difficult to release them. And that's the reason that you cut off the optic haptic junction and leave the haptics inside. Because separating that haptics from the fornices is quite a challenge, and it does damage the zonular support quite significantly.
Yes, Anaga? Yes.
Just one more lovely surgery, Dr. Abhijit. I just wanted to ask you, on table, if you thought you were not able to maneuver it and you thought that there was one place where the zonular dehiscence has started to show, what would you have done at that point of time? What was your plan B? Would you put in a CTR and remove it? Or would you pull out the entire bag and put in an iris claw? And there will have to be some plan B,
Yes.
So I always have all the lenses ready in such cases. So I have iris claw, I have scleral fixation, everything available at the same time. So I keep a CTR and a MH segment also standby. So if I would have had a zonular dialysis, if it would have been just 2 or 3 clock hours, I would have put in a CTR and cut off the haptic there itself using a micro scissor, especially the ones which are, I think, MTR, no, what are those? So those goes through the side port, and you can actually cut off those things through the side port and remove the IOL completely after leaving the haptics in the bag. If I would have noticed even the slightest laxity, I would have put in a CTR any which way. So irrespective of whether I'm able to get the IOL out or not, the CTR would go in.
In this case, in spite of removing the lens properly, would you think, sir, putting in a CTR, like you said, probably later on the zonular dehiscence would
So
show up?
usually when I'm doing the cortical wash, I hold my anterior capsule and I rub it. I'm actually polishing it. So when I'm doing that, if the bag is moving like in circular movements, even slightest, I assume that there is some amount of a zonal laxity and I put in a CTR. In this case, it was not there. So there was no CTR which was introduced.
Yeah, very well done case.
Abhijit, one direct question. You are not some youngster. I have to be generous too and be nice in the sense that one of the first presentations on piggyback lenses I saw in AIOS from you. I thought that was happened even before I started putting piggyback lenses in good numbers. Why did you resort to that? That would have made the surgery much more simpler than this.
Sometimes you need to challenge yourself as well.
First, don't challenge the patient's eye.
Yeah. So even the piggyback was it was ordered. So if I wouldn't have been able to exchange it, I would have put in a piggyback there.
Okay. Thank you very much, Abhijit. Do stay on and we look forward to your discussions. So we shall now go on to our next speaker, Dr. Manik Nicholson, and who's a consultant cataract and refractive surgery from Nicholson Eye Clinic and Hospital. And she's going to show us another very challenging set of videos. Yes, on to you.
Hi, thank you, Dr. Chitra, and thank you for inviting me to this symposium to be among such prestigious speakers. So we have a lot of exciting talks, so I'll just jump right into it. I've been working at the LV Prasads for the past couple of months, so I've utilized their videos, not the Nicholson Eye Clinic videos. We noticed a few interesting instances with the use of Zepto during cataract surgery, and we thought that it would make for interesting learning and discussion. So we have a couple of videos lined up. For those who are not familiar with the device, it's a disposable handheld device attached to a console which is outside in the OT. And the handheld device contains a clear suction cup which contains a nitinol ring, which is the central ring, and it lies on the anterior capsule. The first video is just a regular Zepto capsulotomy video. The cup it's transparent, so it allows for good visualization and you can center it on the visual axis of the patient. And once the device is centered, suction is activated, energy is delivered, and a 5.2 millimeter capsulotomy is created. So what we noticed in our initial days of Zepto capsulotomy was that after completion of the capsulotomy, the suction cup stayed attached to the anterior capsule. So now we always have a second instrument on table, a sort of a blunt instrument to detach this silicone skirt from the anterior capsule. And we've also now started back flushing a little DSS or fluid back into the anterior chamber. This helps detach the skirt from the lens capsule and helps us remove it more easily from the eye. This is also another example of the same incident which happened. The silicone skirt, as you can see, has sort of gone under the cut anterior capsular edge. And the second instrument is used to separate this silicone skirt from under the capsulotomy, and it's then retrieved from the eye. So going on to a couple of more different cases. This was a case of small pupil. Now the advantage is that the Zepto device can be used in small pupils because it's a very flexible device and can be placed under the edge of the pupil, and you can potentially achieve a good capsulorhexis even in such small pupils. And it's quite flexible, so it can be placed under the pupillary margin. Suction is activated, energy is delivered, and again, a second device is used to sort of deliver it from under the pupillary margin. So on the flip side, in such small pupils, if you have a small pupil and if the surgery is being done under topical anesthesia, at times iris tissue can get inadvertently be caught under the suction cup and the anterior capsule. And thankfully, it was not under the ring, and we achieved a complete capsulotomy. But as you can see, the iris tissue did get caught in the suction cup, and the surgeon is having some difficulty maneuvering this Zepto device out of the eye. Even though this was performed from a 2.8 millimeter incision, you can see that there has been some amount of iris prolapse, and keeping a second instrument on table, as I said, is always handy and helps us sort of retrieve that collapsed iris tissue. So the next was a case of an extremely intumescent hypermature cataract. And the surgeon here is using the second instrument to sort of press down the suction cup on the anterior capsule prior to the activation of suction. There's a lot of fluid that has come out, and it's quite evident that if we were using a forceps or a cystotome, it would have been difficult and risky in such a case. And what we noticed after the removal of the device was that there was a small remnant tag of uncut capsular tissue. And this was probably due to the presence, as you can see, of a fibrous plaque, which was then cut with microrhexis forceps, and surgery was completed uneventfully. So the surgeon uses forceps to sort of retrieve that capsulotomy, and that was the end of that case. So another interesting situation which one comes across is an intumescent cataract in which in this case especially, it was quite intumescent. Surgeon is taking his time to sort of center the device on the anterior capsular margin. But if you keep looking at that margin, suction has been activated. You can see that we've had an Argentinian flag, but energy was delivered almost immediately. And so the capsular tear was retained within the capsulotomy. It was not allowed to extend beyond the rim. At this point, we thought that maybe it had extended, but as you can see in this retro image, it didn't. And that tear was contained within the capsulotomy. Most of us operate these intumescent cataracts under peribulbar anesthesia, but this was a case being done under topical anesthesia. As you can see, the patient was a little anxious and was moving on table, which made centration of the device difficult. But if one centers the device on the first Purkinje image, it creates quite a good centered capsulotomy. And it's actually quite easy to do under topical anesthesia as well. So there were a few hiccups we faced along our journey of learning Zepto capsulotomy. That would not be my take-home message. It's quite a safe and easy, fast and repeatable procedure to do, especially in the hands of beginners. So thank you.
Thank you very much, Dr. Manik. I wouldn't know how many in the expert panel use Zepto. So I'm going to ask these questions generally. What would be the contraindications to using doing a Zepto in cataract surgery? Dr. Manik?
Offhand, actually, we've been using it for most intumescent cataracts. And I personally have not used it in traumatic cataracts, but I've heard of surgeons using it in traumatic cataracts, patients with corneal scars also. Possibly an extremely subluxated cataract or one where visualization might be difficult, might be cases where you might not consider Zepto capsulotomy. But otherwise, it's quite a safe procedure with a short learning curve. So
another question which I have, which could be taken by anybody on this platform. Is there a possibility, she did show a case where the iris got stuck, but in a small pupil and the iris is got stuck. Would just having one second instrument be enough to able to release it, or would the vacuum actually get deactivated? Does it make sense at all to use a Zepto for a small pupil? Anybody?
Ma'am, can I answer?
Yes, Naga.
Yes, ma'am. I've been using Zepto for quite some time. And as your question is concerned, in a small pupil, I've also used it with iris retractors. So it's not that you cannot use it, but when you're using a second instrument, Manik, it was a lovely surgery, but I thought using a second instrument when you're actually doing the Zepto is also important. And that second instrument should ideally be a cannula with a viscoelastic, so you can continue to fill in the chamber. So we don't want the chamber to shallow. A very shallow chamber and a subluxated lens, ma'am, I thought would be a contraindication to use Zepto. And what the point that you showed regarding the Zepto getting stuck on the anterior capsule, actually, if you just push in BSS from the other end, you don't even need the other instrument to lift up, because only using the other instrument to lift up many times is not enough. The moment you push in a little BSS, it frees it up, and you can easily remove the Zepto from the eye.
Okay. Any other question, Anaga, which you would like to take? Because I haven't used Zepto.
So I had a chance to use Zepto as a demo, and the first case which I did was an intumescent cataract. So it was a perfect thing for Zepto. And for some reason, what Manik showed, just like her mother, she's a good teacher. And I had an Argentinian flag sign in spite of having that Zepto there. And in these cases, probably I find the femto working much better compared to the Zepto.
Yes.
Maybe the chamber needs to be little nice and deep.
So,
If
so
the
we
chamber
use
is shallow,
we
then
use
there is
viscoat,
more
we use
propensity to
viscoat
bleed.
and Provisc usually, like a soft shell technique for these cases. But in spite of that,
Yeah.
in these cases, probably it's a bit more unpredictable. So we are talking of consistency of a procedure. So in intumescent, probably the femto works much better compared to the Zepto in the number of cases that you would get a nice circular capsulorhexis without it extending out.
Yes, femto, there is no question.
I think related to Abhijit's comment, you know, you both Manik says that these are videos from LVPI, and I know Anaga also has a femto LASIK platform. So when you have this, and the cost of a PI as far as the femto or the Zepto is nearly the same. So why would you use a Zepto if you already have a femto with you?
Sir, it's not the same. Zepto is half the cost.
Zepto is at 10,000.
It's very, very less compared to femto. 1/3 the cost.
Oh, 10,000, am I right? I mean,
yeah. 10,000. Zepto is 10,000, and
10,000.
the PI here is around, for the cataract, if you're using a Lens 6, it's around 18,000-20,000.
Oh, that's the problem. You're using a Lens 6. Okay, you use both, but there are platforms where the cost of the PI is just about 8,000 to 10,000. So, you know.
Yes, but then with the Lens 6, you do get good incision, corneal incisions as well.
Thank you very much. We shall now go on to our next speaker. That was wonderful video, Manik. So do stay connected. We shall now have Dr. Tanvi Haldipurkar, consultant cataract and refractive surgery from Lakshmi Eye Institute, Navi Mumbai, and an amazing surgeon, learned from her father or that innate skill, whichever. She has another wonderful video for us to see. On to you, Tanvi.
Good afternoon, everyone. Thank you, AIOS and ARC, for this opportunity once again to share my video. I'm looking forward to the surgical pearls that our seniors will share here. Of late, I've been served with a litany of hard brown cataracts, and so I'm presenting one here, hoping to learn some tips to do them better. This was a case where the cataract was extremely hard, brownish in appearance on slit lamp. There was a lot of liquefied cortex, which I aspirated with a needle and again re-injected viscoelastic and continued with my rhexis. Now, while making the rhexis, I kept the flap rolled flat, but it was requiring some extra effort, which made me think of some zonular weakness, although there wasn't any phacodonosis preoperatively. With minimal hydrodissection, the nucleus rotated and I started my nucleus management, and that's where my difficulty began. When I tried to bury in the nuclear core, the back kept moving away from the probe. I was using a blunt chopper, which was quite bulky, and while I was trying to chop the nucleus, I noticed that there was zonular weakness on one side. So I stopped there. I refilled the anterior chamber with some viscoelastic, and I tried to get a better grasp. But again, the bag was moving, nucleus was truly evading the probe. So I had to do something different. So what I did is I went ahead and put a CTR ring. I filled the anterior chamber and did that. I changed my blunt chopper to a sharp one. I also changed the settings of my Phaco machine. I increased the power. I shifted to a burst mode with a higher vacuum, and I tried to it helped to increase the grasp. Now, this was a very thick, hard, sticky nucleus, which made it difficult to separate the pieces. But before I could emulsify the fragments, I was making sure it was separated from the bottom plate. Otherwise, I would be pulling the entire nucleus back complex towards the probe. So slowly and steadily, I separated the fragments from its attachments. I was trying to keep the Phaco probe steady and not move too much, so I wouldn't hydrate my main wound or cause too much corneal damage. My second instrument was mainly doing the heavy lifting. I filled some viscoelastic whenever it was required. I tried to clear the central part so I could make some space for working. The last piece, however, was emulsified very carefully because I knew that the bag was loose at the place where there was zonular weakness. Here, my foot on the foot pedal had to be pressed very, very carefully to build a slow vacuum and then release it whenever I was too close to emulsifying the entire piece. Also important to note here is that I'm not really moving the Phaco probe away from its place. It's right in the center. It is the second instrument, which is the chopper, that is getting my Phaco piece close to my probe. It is helping it, nudging it sort of towards it. Now, this is important because there is a loose bag which can get caught with the probe if it does not have any piece occluding it, and it can cause more zonular dehiscence. And once my nucleus was totally out, I made sure that there was no loose cortex or anything lying there. I filled some viscoelastic and took a Y hook just to see if there were any loose zonules or if there was a bigger subluxation than what I had noticed. And as the bag looked pretty stable, I went ahead with the originally planned intraocular lens. Implanting the lens was in no way easy. As you will see now, when this was planned for a hydrophilic lens. When I was trying to dial the lens in, the bag would just move with the dialer, and I was worried I was causing more damage to the zonules. So I was trying to use the spatula there to stabilize the capsular edge, and finally, with a gentle motion, I dialed the lens in the bag and started rebreathing again, which I had stopped momentarily. I was lucky to get away with it, but there are many things I learned from this case. I should have made a larger rhexis to begin with, and when I couldn't do it before, I should have enlarged it later. This would have definitely helped me with my nucleus management and, of course, my lens implantation. And for a cataract this hard, these are some of my surgical steps which I go to. It is important to make an adequately sized tunnel. We have to remember that we'll be spending more time than an average case to break down the nucleus. So it should be adequate that we don't cause too much hydration and then land up into reduced visibility. A slightly larger rhexis, it helps in the nuclear management like it would have for me. It is also important to use the viscoelastics intermittently if the surgery is taking long, obviously to protect the endothelium. And the key to prevent postoperative corneal edema is to keep the phaco probe steady and in the center. We need to use the other instrument to get the fragment to the probe and probably stay in the iris plane. All of these steps are very easy and everybody does it. So, but I think it's important to highlight them here because it's not just important to finish the session.
Can your volume become
high? Volume has gone down.
Yeah.
Sorry, can you hear me now?
Yeah.
Yeah, it is important to also have a clear cornea post-operatively, not just finish the case and have a lens in the back. So the next point is to use intraoperative devices when indicated. Fortunately, I didn't need anything else, but we can also use capsular hooks in case there is a major zonular dialysis. And the most important thing in the end is to just breathe and keep calm because as the senior surgeons that I see here, it only gets better with time and experience. Thank you for your patient listening.
Yes, that was a wonderful video, Tanvi, and showed a lot of surgical skill being displayed. Dr. Swapna, I would, of course, my question was, why did she stay stuck with the small rhexis and challenge herself? But she anyway herself discussed that. What I would want to ask you, Dr. Swapna, is, would you have thought of using capsular hooks and try to do this surgery when the dialysis was noticed after enlarging the rhexis a little bit? Or would you have gone and placed a CTR as and when she did, and with the entire nucleus in the bag and then gone ahead and continued?
Yeah, I think she was right in putting in the CTR because I don't think there was much of cortex in that region to obstruct the passage of CTR or later, whenever you need a cortex aspiration to manage that. But of course, anterior support would have been provided had capsular hooks been placed. But one point I needed to highlight here was that I think there should have been more pieces chopped, maybe 8, 10, 12, whatever you want, because and when you aspirate or emulsify 1 or 2 pieces, that gives you a lot of space in the back to manipulate the rest of them, and there's the tension on the zonules is decreased a lot. So a sharp chopper, like you realized later and used, and lots of wedges to make for a hard cataract, right all the way to the bottom, like you did. So that
one more point that the initial hold was
Sorry, I was just trying to ask, because there was that zonular dehiscence and I was trying not to manipulate it more, would you still want to spend that much time trying to separate? Because the separation causes more,
No. It depends on how you're separating. Okay. Because when you're trying to exert horizontal pressure, but not in a direction that pulls your zonular dialysis towards you. Okay. So that the kind of force, the torque applied is different when
so you're going to use a hybrid kind of a chopping technique, right?
Yeah. So it has to go into the cleft and separate. So
it's going to be a vertical and a lateral separation kind of a thing.
So that decreases and it helps a lot in zonular dialysis.
One more point I want.
For the benefit of all the viewers and the beginners, I would like the panelists to actually put up their parameters, each of the panelists, that, okay, fine, in this kind of a case, what would be their parameters with a gravity-based device? Tanvi, you were using Earthly, right?
Earthly, yes.
Yeah.
Yeah.
So gravity-based device.
There, I think one point I think Dr. Vijit is trying to say is that at one point I thought I heard you say you increase the vacuum, whereas I would have increased the power.
So
power,
power,
so yeah, that was
it was 80. So I probably didn't want to go more. So what would be your settings? I would also be very interested to learn.
I wouldn't put a high vacuum there. I mean, usually I go for something like 500 or on the Centurion. So I would come down to, let's say, around 300 or so. And the power, yes, the power would be what I'd be, concentrating on more, because I want a good hold.
If you were not on Centurion, I want you to be on a gravity-based situation, because that's what all the beginners are going to be on. So what would be your settings in such a case?
I wouldn't have a very high bottle height because of that dialysis you have there. I want to keep the chamber stable. So let's bring the bottle height down to around, let's say 60, 70 from the usual 80 or 90, whatever you're keeping. Put in max power that you can without, creating a problem with the cornea. And vacuum should be very moderate, not too high. Because I usually don't change my settings during the process, like, something for holding and then again for emulsification, another one for the epinucleus. But considering that, I think the basic thing is having a good power so that you're not pulling on anything while you're trying to, chop.
So you need more power than anything.
Yes, Dr. Ramurthy. Yes.
A couple of comments. I mean, a very nice surgery. Tanvi, obviously, genes can't go wrong. Apart from what all was already said, my additional comment would be that, usually I think you never got a proper chop. The nucleus fragments were sort of attached, and Swapna did make a point, you'd sub-chop them into multiple segments. More important that the chop should extend all the way down to the posterior plate. In these kind of cases, what I do is to create a small subincisional trench, and that gives me a better access to the meat of the nucleus, and expose the tip a little more, withdraw my the sleeve a little more, get a deep purchase into the meat of the nucleus, and then go ahead and create a crack. And in case it is not happening right through and through, go into a deeper plane and create, because I found that you are not getting a hold on the nucleus at all. When you are trying to crack, the nucleus is all the time tending to rotate. And sometimes in very hard nucleus, I'm not able to get a crack. All I do is to create the trench into a stop and shop technique. Go right way, all the way to the other axis, create a central thing, make it as deep as possible, put in two instruments, crack them into two heminucleus, and then go ahead and, so cracking into distinct fragments without the nucleus being attached is most important. I personally feel that, sorry to say that, this whatever dialysis you had, which you managed well, was iatrogenically created, because you are trying to maneuver nucleus pieces without really separating them into distinct segments. And apart from the factors you said, when you use the second instrument, apart from feeding it in these kind of hard nucleus, they also help you to protect them from hitting the back of the cornea, along with the viscoelastic which you stressed upon. Once there's less of the nucleus fragments coming in contact with the endothelium, and use the second instrument judiciously to protect that, then again that goes well as far as the health of the endothelium is concerned.
Now, in this particular case where the rhexis was small and the IOL was placed, and when there is zonular weakness, of course, the CTR will take care. There could be these dense hard cataracts, there could be an element of capsulophimosis which could occur in a smaller rhexis. Would any of you, instead of enlarging rhexis, think of making, after the IOL is placed, making small nicks on the capsular margin to enlarge it? Would you have thought of doing that? Or post-operatively, the rhexis is small, would you wait for phimosis to occur, or would you try to make nicks with the YAG laser?
I would actually refashion the rhexis then.
Yeah.
After the IOL was put, we could have extended it.
Yeah. So refashion the rhexis.
Yeah.
Right.
Ma'am, one thing I'm a surgeon, but one thing I do Phaco also, and one thing I've realized, if you are doing wound-assisted delivery in such a small rhexis, if you take the IOL inside and deliver it within the bag itself, there is less of you can say friction or damage to the already that zonular dialysis, because only you have to put the optic into the bag rather than the optic also to be adjusted into the bag itself.
Yeah.
So based on my question, I had actually put up the question for the panelist for the reason that probably we should, in these cases, decrease the aspiration flow rate, because that causes chattering and more turbulence in the chamber, and that is what causes the endothelial damage in hard cataracts. So increasing the power is good, but against that, the aspiration flow rate should go down. The vacuum probably can be medium, as Swapna had said, and that works out very well.
Even regarding the power, just increasing the power could cause corneal wound burns and corneal endothelial damage. So in such cases, at least something like a white star technology will
definitely
help
so
when you
most
have
of the machines are
multi-burst
white
and all
star
that.
now.
Yeah.
Basically, ma'am, the machines we use these days, none of them really cause damage because of power. Like Dr. Abhijit says, majority of the damage is actually caused by chattering. So if you can reduce the amount of chattering, that takes care of the endothelium and goes a long way in doing that.
Thank you very much. We shall now go on to our next speaker, Dr. Shrish Kumar, who's a senior consultant at the Eye Foundation Group of Hospitals and has been with us for a very long time, and an extremely capable dynamic surgeon and very innovative in his procedures and newer concepts. And he's going to show us something different and interesting. On to you, Dr. Shrish.
Thank you, Dr. Chitra and team ARC for giving me the opportunity. And I'm going to talk on star cataract capsulorhexis. We have seen beautiful videos of Zepto in intumescent cataracts from Dr. Manek. I'm just showing a new technique of an inexpensive rhexis technique for intumescent white cataracts. So we all know continuous curvilinear capsulorhexis is extremely important for a safer cataract surgery, as it enables us safe phacoemulsification and in the bag fixation of intraocular lens. And conventional capsulorhexis made by a 26 gauge needle, cystitome, involves a shearing and tearing action on the capsule, which actually increases the risk of capsular tear extension. So increased intralenticular pressure or intracapsular pressure and decreased anterior chamber pressure can lead to rhexis tear, and rhexis tear can extend unidirectionally or bidirectionally. And if you see here, it's an intumescent cataract. The initial linear capsular tear itself can lead to a tear extension, either uni or bidirectionally. And here it is an Argentinian flag sign. Thus, it complicates the cataract surgery. So, by reducing the intravitreal pressure or upthrust from behind and increasing the anterior chamber pressure by injecting visco or high molecular weight viscosity agents, and without allowing the chamber to collapse and choosing a right technique of CCC, we can achieve capsulorhexis in almost all the cases. Now we have what is called a star Canva capsulorhexis, which has got two components, and it's a new manual technique for creating a continuous curvilinear capsulorhexis for intumescent total cataracts. The first component is creating a star-shaped tear in the anterior capsule, and the second component is cannula vacuum rhexis, using a cannula to create a rhexis. So on the left-hand side, we have a total mature cataract, and this is the right-hand side, we have a intumescent total cataract. So we are creating a star-shaped tear in the anterior capsule, which actually distributes tension on the capsular tear margin, and it prevents unil or bidirectional tear extension to a large extent. The second component is using a cannula. This is a 25 gauge cannula, which is a flat tipped cannula attached to a 5 ml syringe, half filled with gases. By withdrawing the piston, you are going to create vacuum, and by pushing the piston, you are going to release the vacuum, and this is used for creating a rhexis. This is called Canva capsulorhexis. So we published this particular technique in JCRS in the year 2019. And further, the next year itself, we published a huge data of around 890 cases in the International Journal of Ophthalmology. And recently, the latest volume of IGO, we published the STAR Canvac continuous capsulorhexis for intumescent cataracts. No. So we included 260 cases of 260 patients, and the procedure is most of the cases we did it under perivulvar anesthesia, and the anterior chamber is filled with the ophthalmic viscosurgical device, and multiple centripetal tears are created in the center of anterior lens capsule in the shape of a star using a regular 26 gauge 60 tone. Then using a 25 gauge flat tip cannula, which is connected to a 5 ml syringe half filled with the BSS. The free capsular flap was grasped with vacuum, and the suction was created. And in a controlled motion, we create a circular rhexis without withdrawing the instrument from the anterior chamber, and thus it prevents collapsing of the anterior chamber. And we are aspirating the liquefied or viscous cortex with the same cannula. And the capsule near the base of the tear is re-grasped several times to complete the rhexis. And the results were excellent. Only one case had a rhexis tear extension, but none of the cases had a PC tear or Argentinian flag sign. And the advantages of this STAR Canvac rhexis is it reduces the initial tear extension, and it's an inexpensive technique, and control the rhexis without withdrawing the cannula from the antechamber is possible. So that it prevents collapse of the chamber, and thus it prevents chances of rhexis runoff to the periphery. So I conclude that this particular technique of STAR Canvac capsulorhexis is a safe and affordable and maybe an alternative promising technique to routine CCC by using the 26 gauge 60 tone or Utrata or microrhexis forceps, or expensive techniques like Femto or Zepto capsulotomy techniques in challenging cases like white intumescent cataracts. Thank you very much.
Shrees, that was a nice one. Can I give you a small suggestion?
Yeah, sure.
You can have a spring attached like what we used to have for the Simcoe on that vacuum cannula for the syringe.
Yeah, it is. Yeah, it is a little difficult to manipulate that.
Otherwise, it would be really difficult to do the in and out again.
Yeah, we can try that. Yeah.
Yeah, that's good. Nice.
Nice. Thank you.
Ma'am, you're muted.
Say that making those small nicks in a very tense intumescent capsule, even those small tiny nicks could just trigger off an extension. What tricks do you use to ensure that you are able to make those multiple small nicks and they stay the way they are?
Actually, the chamber with the I usually use only the low HPMC only for filling the anterior chamber and flattening the anterior capsule. But these usually stays. It is like our old can opener capsulotomy technique. So with the can opener capsulotomy techniques, because of the redistribution of the forces on these capsular tears, the chances of rhexis, the tear extension is less. Yes. Something similar to that.
Yes. I truly understand the logic behind it. And of course, I mean, each of us can do anything, a puncturexis, a small rhexis, and Canvac sounds interesting. And of course, flags. I think there's not too much to discuss here. Anybody has to comment, or shall we go on to the next presentation?
When you aspirate the capsule using the cannula, the capsule being a planar sort of thing, won't there be a lot of space around it through which the contents of the anterior chamber, like the viscoelastic you have inserted, also gets aspirated, and therefore there's a tendency that unless you keep on refilling the chamber, the volume cannot be maintained?
No, actually, like we are going forward.
Shrish, louder.
No. Usually the chamber collapse doesn't happen with this technique. That's the beauty of this technique. We are not coming out of the anterior chamber, and at the same time we are aspirating. Sometimes it will be difficult to aspirate to viscous cortex, but semi-viscous or loose cortex or the milky cortex, it's very easy, and it is possible. Like you are creating a space between the capsule and the nucleus by aspirating the viscous cortex, and you have enough space for holding the capsule either from the anterior surface or from behind the under surface of the capsule.
No, my question was
can hold it either way.
So, Swapna, I'll answer your question. I do a lot of viscoeless cataract surgery. Okay, so when we are doing viscoeless cataract surgery, we can do rhexis with either a needle with irrigation going from the left hand, or you can make a nick on the capsule with a needle and then complete the rest of the capsulorhexis with the aspiration port, like an irrigation aspiration bimanual. And when you're doing that, the main problem is that when you're holding, even if the viscoelastic is not there, it's only pure saline. The only issue is the fluttering of the capsule. So what you have to do is you have to actually put the irrigation over the capsule and then holds it flat over the lens. And then you just have to hold it with the aspiration and complete your rhexis. Hold the capsule, complete your rhexis. So he's doing it manually with the syringe. That's the only difference. He can
but
actually
there is no
do it with an
irrigation. There is
aspiration.
no inflow is my point.
So he's using a viscoelastic along with it.
No, it is
or the balance also.
I fill the chamber once before starting this, and then I go with the syringe, which is half filled with BSS. I go very close to the tear, the cut capsular margin, and aspirate the this thing capsular margin only. That's the back surface of the capsule. So we are not aspirating
I agree. So it's basically the same premise, the same technique. So either you're doing it with a syringe or you're doing with the machine. So it's going to be the same technique. So you're going to be holding the capsule and tearing it off over that. And it's much more control, believe me, compared to the needle.
But then what is the benefit over holding it with a rhexis forceps? This technique.
The moment you're opening up a bigger wound, the viscoelastic that comes out is much more. If you're going into the side port,
doing it through the side port, no?
Yeah.
So yeah, definitely. So there are many more ways of reaching Rome. So this is just one more way.
One more way. Yeah. Right. Thank you very much. We shall now go on to our next speaker, Dr. Mukesh Dholakia, who is again a specialist in cataract, glaucoma, and medical retina from Dholakia Eye Hospital and Laser Center, Gujarat. And we look forward to what he has to show to us. Yes, Dr. Mukesh, are you there? He was there.
Yeah. So good afternoon, each and everyone, and thank you, Chitra ma'am. Should I start sharing my video?
Yes.
Yeah, and audio is there with it.
Yes.
Nucleus drop, a case discussion by Dr. Mukesh Dholakia, Gujarat. The first step, CCC, is well managed. It was round and circular. The second step, hydro procedure, is also as usual. I feel nothing wrong. It was there. Once the hydro procedure completed, we moved for nucleus management. I felt the nucleus is a bit soft, but compact and cheesy. But it was not difficult to manage. In such situation, I manage the case by doing 4-quadrant crack technique. So as usual, I am doing 2 cutters and will try to separate the 4 pieces of the nucleus. As I said, nucleus was resistant to crack. So again, I'm trying to move and trying to get first crack of the nucleus. I was not getting proper 4 crack in the nucleus. I thought I got first crack of the nucleus. So this portion of the video I recorded, I'm showing you in slow motion. Here we will see at what step nucleus get dropped into the vitreous. So I thought I am catching apex of one piece of nucleus, and here as you see I'm almost to catch the apex of the nucleus. And suddenly nucleus goes into the vitreous cavity. Whole nucleus jumped into the vitreous cavity and nothing left for me to manage. So what was wrong? That I was thinking, and when I saw whole procedure 3-4 times, then I found the main culprit step for all this tragedy. PC gave away during this step what I personally feel. Can you see this snipping effect? At this particular moment, PC was blank. You spare your time. Thank you.
Thank you very much, Dr. Mukesh. So what video takes us back right to the basics about hydrodissection pearls. Like what we need to understand is when you're doing as straightforward and a simple step as a hydrodissection, we need to always burp out the visco, we need to decompress the bag, and then only do a repeat hydro, or else this kind of a pupillary snap sign or a capsule blowout can happen. Yeah. Now, supposing the situation was that you have seen the pupillary snap, the nucleus is in the bag, would you at that point itself, instead of going on to any other step, think of doing something different? Dr. Vavikar, are you there?
Yes, madam, I'm there.
Yeah.
Even if there is a pupillary snap, at this point of time, it is not necessary to stop doing Phaco.
Yes.
I would fill with a good visco, probably cohesive one. And another problem, what I saw in the video was that a plate was created. So there was no place to hold and chop. So the chopping should have been done much before going too deep. If that was done, probably, would have saved the day. And then another thing is that once you get a 2 heminuclei, then best thing would have been to get the nuclei into the heminuclei into the anterior chamber and look for PC rent, and then manage the case accordingly, either putting some kind of scaffolding between the nucleus and capsule, or if PC rent was not there, then putting a good visco above and protecting the cornea.
Dr. Swapna, your thoughts about
if I realize that I have
yes.
Yeah, if I realize that I have blown the capsule out, I'll convert immediately.
Yes.
SICS and bring the nucleus.
Yes.
No more.
Madam, would I say something?
Who's that?
Yeah,
yes.
Dr. Dalit.
Yes, yes, yes.
Actually, when I was proceeding for the Phaco, I didn't notice anything snip side because it was so fast, and I never knew that this mishap can happen. So it was only retrograde notification that because of the hydro procedure was at fault, all this thing has happened.
Dr. Dholakia, what were your settings?
Actually, I'm using Venturi system. So in Venturi, we have only two things: irrigation and vacuum.
Irrigation bottle height was how high?
100 centimeters. That's usual.
Have you counted? Have you actually measured it at 100?
Yeah. Actually, I'm a tech guy, so I myself have devised one, up and down device myself. So it is 100. Okay. It is definitely 100.
So, Dr. Vavikar, would you actually have a separate setting for such a case then?
Yeah, that is a very interesting question. Talking about what Dr. Swapna Nair said, does pupillary snap sign mean PC rent every time? So that is why. So that is why I would not like to convert at this stage. And that is one important point brought forward by Dr. Abhijit, is that I would definitely be gentle with the setting. So I will get the bottle height down and aspiration flow rate low, so that I am doing the surgery in a slow motion, and increase the vacuum as well as power, so that I am troubling the capsule much less. And then go ahead, what I said in the
here actually it is not just the snap that happened. Yes. Dr. Dholakia, a lot of problems rotating the nucleus as well.
It was
so there was always an indication that was not
something.
Can I add? Can I add, madam?
Yes.
In the process of doing 4-quadrant technique, he debulked the nucleus, whole nucleus, central core heart nucleus is debulked out, and he's left with no nucleus to hold on.
Yeah,
that was a problem actually.
Exactly, he was left with the plate.
If you would have used a quick chop technique, the nucleus would have been in 2 segments, and that would have been brought in the anterior chamber, and just like madam said, would have converted into SICS and visco express the fragments.
And one more thing, sir, I want to add over here. The patient was very high myopic. Anterior chamber axial length was almost 31 millimeter. So that because of high myopia must be, low rigidity of the sclera might be, one of the causes.
In the face of the pupillary snap and the manipulations in the capsular bag was additive. So as Dr. Chandrasekhar is saying that if there is a pupillary snap, if you don't want to be conservative and you still want to proceed, then you should be thinking that you're going to be operating on an open capsule and take the adequate precautions to do and be prepared anytime for a nucleus to go in. And maybe if you're very careful, it was just a small area of rent, you might escape. Now, one last word in a soft cataract, as briefly as, I asked Swapna to tell me, what are the challenges in a soft cataract surgery? What would be the sure shot technique to do in a soft cataract? Because, sometimes theoretically, it's not the same thing which works out in a soft cataract. Would you like to flip it out if it is a very soft cataract? This wasn't that soft a cataract. What would you like to do?
In a soft cataract, basically, when you try to get a hold over there, it gives way, and you keep ultimately make a large crater, and then there's nothing to hold on to and aspirate. So if that happens, then flipping, I think, would be good, because you've already debulked it, and you can just put some visco on the margins and topple it, and it can be flipped easily. But my basic technique is not to go too deep inside and not to use too much of power. So what I do is I try to hold, and then right from the periphery, I drag my chopper to the center without actually using too much of power and, burying into the nucleus and chopping centrally. So I go under the capsule and bring the chop towards the center, and then divide the pieces like that. So it's just using vacuum that I do that. And that gives me, let's say, 4 pieces should be enough to, make sure that each one comes out individually.
Swapna, what is your vacuum setting for a soft cataract? The vacuum that you would use? And would you actually wait till it occludes?
No, it depends. I mean, the soft cataract, if I have something with is just posterior subcapsular, there's nothing of the nucleus, much of the nucleus here, or in a very young patient, I am not going to wait for it to occlude. I'll just hold it mechanically and then drag my chopper right from the periphery to the center, because that hold, or it just keeps on aspirating. You cannot wait for it to.
You lose your occlusion. So yes, that's what the point he was trying to bring out. In flax, in a soft cataract, just one last word before we go on to our next speaker. Would you all think of doing a softening technique, or would you all only create fracture planes or chops?
There is no need.
Yeah. Yes, that's the point I wanted to bring forward. Ramurthy, you have anything to add? Shall I go on to the next speaker?
Yeah, go ahead. I think most points are covered.
Yeah. So we have our next young speaker, Dr. Supriya Samak Sriganesh, who is a young consultant and Phaco in refractive surgery in Netradama Super Specialty Hospital, and she's going to show some gymnastics to us in the next few minutes. On to you, Supriya.
Good afternoon, everyone. At the outset, I would like to thank Chitra ma'am, AIOC, and ARC for this opportunity. Very honored to be here. So today I'll be showing the video of, is my screen seen?
Yes.
Okay, so this is a dense, almost black cataract with a mid-dilating pupil. It was around 5 to 5.5 mm. So I'm just going to play the video. So here, I'm making a simultaneous side port and a clear corneal incision using a diamond blade, the side port. I like to stain this capsule and wash off the stain. Here, the pupil is too small, so to be on the safer side, I'm using a Maligan ring to expand the pupil. It comes with its own injector, and while the last loop, I use a collar stud dialer to actually expand the pupil with the last loop, and use the injector itself to put it into place. I'm using a cystitome to do the capsulorhexis. And if you notice on the right side of the capsulorhexis, I do leave a part of the stained part of the capsulorhexis, just so that I can see the capsule edge. Very good hydrodissection is important in such cases while using this device called the MyLoop device. So I'm just going to pause here. This device is called the MyLoop device. It's actually a nitinol loop, nitinol filament loop, which is 300 microns thick, and it has elastic properties. So it expands up to 10.5 millimeters. So what we do here is we expand the loop beneath the anterior capsule, and it expands all the way to 10.5 mm, and this encircles the entire nucleus. Here I use a second instrument to stabilize the nucleus. There's a retractor which can retract the loop and divide the nucleus into half. So with such a hard cataract, it's very useful to use this and reduce the phaco energy. Here you see that I'm rotating the nucleus, but not completely horizontally. It's a little oblique, because for the second cut, when we go in, the opening up of the instrument itself rotates the nucleus a little bit, and it comes into horizontal position. So here you see the black band on the instrument. It has to be there at the incision. That's the correct position. With the second instrument, actually it holds down the nucleus and prevents it from tilting up. So at this point, I'm using viscoat to deepen the anterior chamber and start with my phaco. Here you see that the nucleus pieces are cut through and through, and this really helps bring it out from the bag, and the phacoemulsification is much easier. Of course, it can be chopped into smaller fragments if it's difficult to remove the first fragment. I keep injecting viscoat again and again to protect the endothelium, because as you can see, it's a rock hard nucleus. I'm keeping my chopper right above the fragments so that the fragments don't fly and hit the endothelium, just to protect the endothelium. The very last piece, I do try and chop it further after injecting viscoat again before emulsifying it. So actually this instrument has helped us reduce the phaco time and phaco energy quite a lot. And it uses centripetal forces, central forces rather than centrifugal forces to actually divide the nucleus. Now here, when I'm injecting the lens, what happens after all that work is that the trailing haptic actually gets stuck in the cartridge. So I try to push through a couple of times and that doesn't work. So I I retract the injector and then try to push again. I retract it completely and try to push again. And luckily the trailing haptic finally goes in. And then I dial the lens in with a little more viscoelastic. Now to remove the lens, I use a remove the Maligan ring, I use a collar stud dialer to release the trailing loop. And with the injector itself, I hook it and retract it back into the injector. So this is an easy way to actually remove the ring. So that's the end of the case. Just remove the viscoelastic and hydrate the wounds.
Wonderful video, Supriya. A very challenging case, and your tips for how to place MyLoop and how to do about it was truly amazing. As if you were a very seasoned surgeon. So kudos to you.
Thank you so much.
As far as the questions are concerned, I just want to know, the pupil was moderate size. Is it because to use a MyLoop, you need to have a larger size pupil made you use the Maligan's ring?
Yes, ma'am. This was just to be on the safer side, because to use the MyLoop, and since it was such a dense cataract, for better visualization, I decided to use the pupil expander.
Would you feel that using iris hooks would help better than a Maligan ring crowding the area and then you needing to put the MyLoop inside? Just a thought. Anybody in the panel could answer me. It is a genuine doubt I have.
Ma'am, actually, the Maligan ring doesn't really crowd the AC too much with whatever cases that I have done. The thing about iris hooks is, again, multiple incision. Of course, it would give you a better exposure, but in this case, the Maligan ring expands to about 6.25 to 6.5 mm, which I felt was enough to manage in this case. And to use the MyLoop, actually, it doesn't crowd the AC too much. The MyLoop actually is quite a thin instrument, even though it looks quite bulky in the anterior chamber. It's easy to use and manipulate.
Yes. So going further, this is another way of skinning the cat. Just one question I have is to the expert panel. If you were to be on the flags and you have this kind of a hard cataract, what would be your segmentation pattern and spacing? And that's what I want to ask. Ramurthy and Swapna.
Oh, either the two ways of doing it. Either you can just use a grid pattern and just use a 200 microns grids, very small grids. Otherwise, you can use softening as well as segmentation. Usually a really hard cataract, I go ahead and use 8 segments with a softening of about 300 microns, a combination of the both. That, of course, increases the amount of time for which the femto has to fire, but that's not too deleterious. And usually, I keep the offset at only 500 microns.
Yes, Swapna?
Yeah, I think that's pretty much.
Okay.
On the femto platform, even I would do the same. With it would be a grid with segmentation.
Yes. Very good, Supriya. So do stay on, and we have our next speaker, Dr. Neeraj Sandhuja, who's the founder director of Vian Eye and Retina Center, Gurgaon, and he has a different, interesting case to show. On to you, Dr. Neeraj.
Thank you, Chitra ma'am, and good evening, everybody. I'll be showing a little bit different when any complication of cataract surgery has already happened, like dropped intraocular lens. And this was a case of spontaneous subluxation of the intraocular lens into the vitreous cavity, and the patient was sent to us. So we had planned for glued IOL in this patient. You can see we are making scleral flaps 180 degree apart in the horizontal meridian. And the thickness of the flaps have to be done in such a way, like it should be 2/3 anterior and around 1/3 posterior thickness. And it has to be done with a crescent blade. And you can see that scleral flaps have been made. Now on the opposite side, we are making a scleral flaps. Now the scleral grooves are being made, which are going along the circumference of the limbus. And you can see with the this 26 gauge needle, we are making scleral flaps, and haptics have to follow that And after these scleral flaps have been made and grooves made, we are putting a trocar cannula and now making a 20 gauge entry. Now the globe is formed and we are making a 20 gauge entry into the 1.5 millimeter from the limbus into the vitreous cavity, to which the haptics of the intraocular lens will be put. Now you can see the whole capsular bag and intraocular lens is lying over the vitreous, over the retina. And now this thing is being held with end gripping forceps and brought into the anterior chamber. And we are holding with the end gripping forceps, which are 23 gauge forceps. And gently we are prolapsing this intraocular lens into the vitreous cavity, taking care the cornea should not be touching the lens. And once this lens has been prolapsed into the anterior chamber, now it will be explanted through the corneoscleral section. We are putting viscoelastic into the anterior chamber and enlarging the corneoscleral section. Everything has to be done in a very systematic manner. And you can see we are pulling this intraocular lens gently with 2 instruments, and this will be brought out of the anterior chamber gently. And you can see, and infusion cannula has to be on because the intraocular pressure has to be maintained throughout. Now this IOL bag is there, and now we are going with a end gripping forceps into the vitreous cavity through the scleral entry which we made, and going with A-type injector and injecting 3-piece lens. And the leading haptic has to be caught at the edge of the haptic itself. And you can see that the lens, one way the lens is being injected and the other way the haptic is being brought out very gently, so that you should not damage the haptic also, and it should not break also. And it has to be held at the tip of the haptic only. And now you're making space for the optic to go inside. Now your assistant holds the tip of the haptic, and you have to go through with the end gripping forceps from the other side. And you now gently hold the other trailing haptic with the McPherson forceps and take it into the vitreous cavity, and then just gently bring it out along the circumference of the globe itself, because you have to be very cautious. You should not break the haptic at this juncture. And once the haptics are out, you can leave it comfortably. It will not go inside. It will not just retract inside the vitreous cavity. Now you are tucking the haptics into the scleral grooves which you have made, and it has to go along the circumference of the globe. And this also has to go along the circumference. If it is not along the circumference, you may land up with some astigmatism because the IOL may tilt also. So this is very important. And once the IOL is in place, we are putting one single suture because the section was enlarged because of the IOL explantation, and we are taking out the infusion cannula. And you can see throughout we had maintaining this intraocular pressure also. Now putting the glue over the scleral flaps and just doing it over the other side also, putting scleral flaps back in place. Now keeping the conjunctiva over there. And this is how we can do all drop intraocular lenses or any drop lens where posterior capsule or anti-capsule support is not there. We do it with the glued IOL. Thank you very much.
Yeah, excellent demonstration, Dr. Neeraj. So the tips are that the 2 scleral flaps should be exactly 180 degree apart, 2 millimeter from the limbus, and we should ensure equal amount of haptics are being tucked in, and so that there's no tilt. And I suppose the other important thing you said is you should hold the tip of the haptic so that it doesn't break. But I'm going to ask you one question here. Do you think when you're doing a glued IOL, this was anyway a combined retinal procedure also, but if you're just doing a glued IOL, you've not had an IOL drop, but you have lost the capsular bag, would you believe that just doing an untreated vitrectomy is enough? Or do you think they do better if a pars plana vitrectomy is done, the outcomes are better? Is one question I have.
Yeah, actually, I'll tell you with my personal experience also. Once some retinal surgeon is doing this procedure, glued IOL, or some anterior surgeon is doing, mostly they pump up a lot of viscous into the anterior chamber, which goes into the vitreous cavity and causes a lot of inflammation, glaucoma in the postoperative period. By this trocar cannula, putting a maintainer, so the need for a lot of viscous fluid is avoided. And second thing, once you are making the scleral entry into the sclera, 1.5 millimeter from limbus, sometimes you land up into bleeding also. And I've seen people having a lot of vitreous hemorrhage once this glued IOL is done. So if being a retina surgeon, if we are doing so, we are able to control all these complications on the table itself. But yes, it can be done.
So you believe that instead of using an AC maintainer, doing a using a trocar cannula and a pars plana vitrectomy would be ideal, and the whole thing managed by a retina surgeon would be the best way to go.
Yeah, because any surgeon has to be trained by.
Yes, I agree. So the other one simple question which I am going to ask is, does it mean that keeping in mind, of course, those late in the bag dislocations are very rare. It's not happening often enough. But does it tell us in this podium here that we think of using a CTR for a high myope or a retinitis pigmentosa case, or in a case of a PXF? Do you feel there is an indication at all, or all of us believe that these things have to be taken on a case-by-case basis?
I think this thing should be taken on a case-to-case basis, because patients who have undergone vitrectomy in previous time, they are more likely to develop such type of spontaneous dislocation of the intraocular lenses. But generally, rarely seen pseudo solution people developing such kind of spontaneous dislocation.
A CTR won't prevent the zonules from giving way. So you'll have the whole IOL bag CTR complex going down, rather than it being protective. So if you have something sutured like a CTS.
And then actually taking out this endocapsular ring is, I think, a more uphill task than taking out IOL, because it is such a thing. You have to take it out without damaging the retina. I've done that. Even one friend of mine, he did the scleral fixation IOL, patient developed glaucoma because of the vitreous hemorrhage. Surprisingly, when I had gone inside, I saw a large endocapsular ring also improved. So I had to take out the vitreous hemorrhage, control glaucoma, and take out the endocapsular ring through the gap between the scleral fixation IOL and the iris without taking out damaging the
So a good idea to remove the endocapsular ring is to actually cut it into 3 or 4 pieces, because that makes it easy to get it out.
I understand, but if you go with considering the anatomy of the globe, you are taking in a very circumferential manner. I've got that video also, but so it is also because cutting the PMM different pieces may cause a lot of injury. When you're trying to pick it over the retinal surface, you can damage the retina.
Yes.
These edges are sharp once you cut it.
Yes, yes. Thank you very much for the very important points brought out. Thank you, Dr. Neeraj. We shall now go on to our next speaker, Dr. Avinash Bhagzai, who is again a senior consultant at the Center for Sight group of hospitals at Indore, and he is going to be showing us his video. On to you, Dr. Avinash.
Thank you very much, ma'am. Let me thank you personally, the AIOS, the AIC Managing Committee, to give me this opportunity to present myself in front of all of you. Anandji, can you please help me with the video? Can you please start the video?
So just give me a minute, sir.
So I'm here demonstrating an impending nucleus drop to be managed with a relatively simpler technique called as posterior optic buttonholing, commonly known as posterior optic capture. So I'm just going to demonstrate how can we manage such a case, and how can this technique help us in managing otherwise, commonly encountered PCRs as well. Yeah. So cataract surgery is one of the most commonly performed surgeries
across the world.
I guess. Okay. So cataract surgery is the most commonly performed cataract surgeries across the world. But we as cataract surgeons always fear a posterior capsular rent, which can occur in any of these simple cases to the complicated cases like posterior polar cataract. And we sometimes, face a problem managing such cases, especially with the IOL centration and the postoperative AC reaction are the commonly faced challenges by us all. So here I'm demonstrating this technique POBH, in which the optic is buttonhole, just like a button is tucked in, into its place. So in this technique, the optic of the IOL is placed just behind the anterior capsular margins, just like the button. As you can see that the blue edges of the optic are just behind the circular anterior margins of the rhexis. So the ideal size of the rhexis should be 4.5 to 5.5 millimeter diameter. And the best advantage of this technique is that it forms a watertight diaphragm, preventing any further movement of the lens. So here in this case, this is a posterior polar cataract. Routine phacoemulsification steps are being performed with all the precautions which we normally follow in a posterior polar cataract. A central circular round rhexis is being made, and routine steps like hydrodelineation is being performed instead of the routine hydrodissection. As we proceed with the Phaco, stop and chop technique, here we were making a trench, and while making a trench only, we realized that there is a sudden deepening of the anterior chamber, and the nucleus was found to be becoming unstable. It was kind of sinking down, and then we kind of rotated back it into the bag. The Phaco was abandoned and the procedure was converted to an SICS. Superior-temporal tunnel was made so that we be sure that we don't have to apply sutures in the end. Again, the nucleus was dialed back into the AC, and with the help of an irrigating vectis, the nucleus was taken out of the anterior chamber. And then a meticulous anterior vitrectomy was done, and the remaining cortical pieces and the cortical matter was then removed with the irrigating vectis. And after making sure that there is no more vitreous in the anterior chamber, the rent margins, the anterior capsular margins were reassessed. And you can see in this photograph that the circular anterior rhexis margins are very well made out. And we proceed with the implantation of a 3-piece IOL in the sulcus. And you'll see the very important step now. You just push one edge of the optic behind the anterior capsular margins, and then the other 180-degree opposite, you just push it slightly posteriorly behind the anterior capsular margins, giving you a very well centered IOL. And you can see the dial is very well centered. There is no postoperative reaction. And the advantages of POBH are it reduces the postoperative anterior movement of the IOL. The pressure is not raised a lot. There is lesser AC reaction postoperatively. And there is no difference in macular thickness compared to the standard in the bag IOL placement. And the other advantages are that it lowers the chances of iritis and the pupillary block syndrome. It creates a very good centration, and also it relatively stabilizes the vitreous space, so it reduces the chances of a retinal detachment as well. So the message to take is, do not panic. Even if you encounter a PCR, you can convert from Phaco to SICS or ECC if required. And the POBH offers a very good technique in all such cases to prevent postoperative complications in which you cannot place the IOL in the bag, like in traumatic cataracts with a large anterior capsular rupture, or absorbed cataracts, or very large PCRs which prevent in the bag IOL placement. Thank you.
Thank you very much, Dr. Avinash. Let's go on to discussing. I'm going to take this question with Dr. Ramurthy. Now, if you were to do an anterior optic capture, would you change the IOL power? If you were to place the IOL on the rhexis, would you make a change in the IOL power? If it is going to be a different intraocular lens to that which was planned in biometry, would there be some changes which you incorporate? I think I would want this question to be answered for the young audience.
Oh, actually, when he was presenting, I was thinking one of the advantages of creating an optic capture is that you don't have to change the IOL power.
Yes.
And so you can go ahead and stick to the IOL power that was originally planned. Yeah. And when you are shifting to the sulcus, one of the dictums is that you reduce it by about 0.5 diopters. But again, it depends upon the power of the intraocular lens that you're implanting. So there is something called Uday Devgan talks about this rule of 9, where if the power of the original lens is less than 9 diopters, you don't have to make any change at all. If it is 9 to 18, you make a change of 0.5 diopters. 18 to 27, it's 1 diopter, and above 27 is 1.5 diopters. I use that. I mean, of course, very rarely this comes into play, but it does make sense because the higher powered lens, as you displace it anteriorly, the amount of reduction that is needed is likely to drop down. And a couple of comments regarding what the video that was shown, very nicely managed. One thing was that, when you have, anytime you have a vitreous loss, I think in today's world, you must use triamcinolone acetate to make sure that complete anterior vitrectomy has been done and there are no vitreous strands in the AC. Just getting a round rhexis or a round pupil is not good enough to tell you that there's no vitreous in AC. Even whenever I have had no vitrectomy has been done also, if there is a PCR, even after placement of the lens before coming out, closing the case, I just put a little bit of diluted triamcinolone, and that often shows up one or two strands which can be handled right away. And that does help in better outcomes.
Identifying the vitreous.
Since we are talking about optic captures, I think
one other factor I want to say is that, when you are doing all these maneuvers, invariably viscoelastic goes into the vitreous cavity. Ph was saying in the previous instance, before creating the optic capture, is extremely important. You keep the irrigation cannula in the anterior chamber, go with your aspiration cannula behind the optic of the lens, and then remove all the viscoelastic that invariably seeps in there, and then just nudge the optic of the lens with your aspiration cannula itself, which will create a nice optic capture if the rhexis of the right size. Otherwise, this will lead on to raised intraocular pressure, inflammation, which will take a long time to clear up.
Sir, I remember some video about Dr. Osher. He had shown something about how vitreous is actually helping us with the cataracts. Could you elaborate on that with the slow-mo, with relation to the slow-mo Phaco?
I'm not able to catch your question, Abhijit.
Can you explain yourself, Abhijit?
Can you hear me?
Yes.
Yeah, I can hear you.
What are you? Can you convey?
So there was this video which I remember of Dr. Osher, how he showed that the vitreous actually doesn't pull it down unless the vacuum and the settings are really high.
Yeah.
I think he means to say that the vitreous, an intact vitreous face actually helps in supporting the nucleus and preventing it from falling.
Yes, it does.
It does.
So could you elaborate on that?
Another thing which all of us are doing, but if there is a nucleus dropping, it's an anterior vitreous phase. Now, if in those setups where you have a retina setup, good setup there, would you like to go in with your vectors and get the nucleus even if it's in the anterior vitreous plane, or would you like your retina consultant to take on from there? I want the thought of the experts.
So I was talking about the slow-mo Phaco here, because instead of going in with the vectors, he could have actually converted to a slow-mo Phaco here and finished the cataract with the Phaco emulsification as well.
But then you're pulling at the vitreous base, from so many places.
And no, the vitreous base does not get pulled at that stage. The moment you realize it and you're converting it to a slow-mo, the vitreous even doesn't come ahead. It doesn't herniate.
I think
then you should bring the nucleus forward and do a supracapsular Phaco maybe, but again those pieces and you should keep injecting viscoelastic all the time, viscoed, so that the vitreous continues to be behind.
I agree.
Take on this, Abhijit, would be that if the anterior hyaloid face is intact and there's no vitreous disturbance, then maybe you can use a dispersive viscoelastic to tamponade the vitreous, even put in an intraocular lens either in the sulcus or in the back to hold back the vitreous, and whatever nucleus fragments, cortex is there, then you can go ahead and handle it. But if vitreous has already come into the anterior chamber, got mixed up with the lens material, I think any maneuver that you do without handling the vitreous is going to create a significant traction on the vitreous base and lead to problems.
Yeah,
definitely.
While we are on optic capture, there's one other information, like supposing a person has placed a lens, does a reverse optic capture as a last minute bailout situation. I would want expert panel to comment that what problem can happen post-operatively, the residual myopia which can happen, and is that something we have to be left to handle with because you have just managed to somehow center keep the lens captured? I suppose you can't do anything because the lens is already in the bag, right?
Most often when you're creating a reverse optic capture, you're least bothered about a 0.5 diopters power being there.
Yeah. It is just that I wanted that point we brought out.
Actually.
So Anaga, anything to ask? Shall we go on to the next? Yeah, so we have our next very energetic panelist, Dr. Sanjay Rassel, who's going to be talking, and he's a consultant at Sanjay Netralaya, Maharashtra. And we look forward to another very interesting video which he has to show. On to you, Dr. Sanjay.
Sanjay, you're muted.
Sanjay, can you unmute yourself?
Am I audible?
Yes. Yes.
Yeah.
But your
So I
video...
said, good evening, very lovely panelists over here. And thank you, Chitra Madam, for having me here once again in this ARC program. I given a name to this video, Picture Abhi Baki Hai Mere Dost. Just Shail Vasavda has already highlighted, don't take the things for granted until you finish the case totally. And when you have a Sunday with exhaustive discussion on cataract surgery, I don't expect everyone to be as fresh on the Sunday morning. So the same thing happens when you have a heavy OT day and you have a last case, your IOL is properly loaded, you have done a wonderful Phaco, and it's a matter of just hydro implanting the IOL, and you are eager for the coffee break. Now you are injecting the IOL and you have a situation where you see your IOL is totally crushed into the anterior chamber. Now, here I request Chitra Madam, I request permission from the Chitra Madam to pause this video because I want to ask few questions here. Why this happened, what could be done, and how this can be prevented in further cases. The case is open for discussion, Chitra Madam. And we will see a remaining part of the case after the discussion.
Was there not enough visco loaded while you were implanting this lens?
That's why I already showed the loading of the IOL at a first place. If you see, there is a copious of visco is placed onto the cartridge on both groove, and the IOL was well.
Was it a wound assisted thing where you put too much pressure, or the plunger was overriding?
No, see, it's a hydro implantation of the IOL, and it is not a wound assisted. My distal tip of the cartridge is well inside the anterior chamber.
Yeah, then
was this a new IOL?
New IOL, the material of the IOL is questionable here.
IOL
it's a hydrophobic IOL, hydrophobic single piece IOL.
Is this a new IOL? Something that you have not used before?
It's a revision from IOC. It was a new IOL, yes.
So maybe some of these.
So there's a problem with the compatibility of the new IOL with the injector that you're using,
or with the cartridge.
And probably it will be in a learning process. So you were one of the first targets.
No. You are right. Could be that cartridge that is provided by the assistant, and the assistant might have opened another cartridge. That is one possibility. But what I feel that for several years I am hydro implanting the IOL, and I thought why not to save the time. Every time I need to exchange the IA from left to right for the cortical aspiration, rather than exchanging the hands every time and coming out and loading the IOL. I loaded the IOL before IA and kept on the trolley, and it got stiffened. It got hard in the cartridge. By the time I finished IA, the IOL material got very steep and hard, and I really felt the resistance while injecting the IOL. It was really impossible to inject. I kept on pushing and pushing. At that time only, I could have stopped injecting the IOL and withdrawn the procedure there only. But I was eager to have a coffee break just now. Like we all must be feeling that desperate coffee break after a long time of a discussion. So in the eagerness of having coffee break, I landed in a trouble and extended my OT session half an hour. So I rotated this IOL to bring this cut part in along the tunnel, and I had no option but to cut this IOL in a multiple small pieces with the IOL cutting scissor, that is a crocodile scissor. Copious amount of viscoelastic, that is cohesive and dispersive visco, is injected below and above the IOL to protect the delicate structures like corneal endothelium and posterior capsule below, and of course the CCC margin, which is very important. This IOL is again divided in two pieces. Every time the Sinsky or dialer is kept into the entry chamber onto top of the IOL piece to support it, should not tumble and should not damage the corneal endothelium, and the IOL pieces are cut in two pieces, or IOL fragments are made in a controlled fashion so that we don't touch the corneal endothelium.
Can I ask?
Hello, is the video visible?
Yes, it's visible.
I think there is a lag.
Moving
or is it playing in a very slow motion?
Yes, it's going very slow. Yes.
Sanjay, can I ask a question?
Yeah.
Yes.
Was it an unusually cold day, or was it that the blow of the AC?
AC temperature was literally on the 16th on that day.
I think sometime it could also be that the lens was stored in a very cold place and it did not get adequate time.
No, we keep the lens outside the operation theater, so that it becomes very warm and malleable. But here the problem was it was loaded way before the IA procedure was done, so it got stiffened in the cartridge itself.
Yeah, maybe these are the cases wherein if you have do a screw type of injector, maybe I wanted Dr. Ramurthy to comment on this. Instead of pushing it, if you had a screw injector, this kind of breaking up may not have happened because of a more controlled entry.
I think Dr. Sanjay already mentioned the answer in the sense that irrespective of going into why this happened, whenever you feel irrespective of the type of injector you're using, if there excessive resistance, is better not to force the lens inside. It might be because the appropriate cartridge in the intraocular lens is not matching, or there is overriding of the plunger onto the optic of the lens when you have this problem. So whenever you face a situation where you have to excessively force the lens inside, means whatever be the modality of injection, it's best to withdraw, inject it outside. Very often you'll find that the lens is broken into pieces. Go for an alternate lens so that you don't end up in a situation like this. Of course, he has handled it quite well. Only comment I would have is that, like Abhijit showed, it's always a good idea to have a lens holding forceps through the side port so that it stabilizes the lens. And then
always have a second instrument from the left side of the side port to support the IOL. So many times these scissors, they are sterilized and repeatedly used, many times used. They may not work every time effectively as they are fresh. So it's always better to support the IOL fragments. They have a tendency to tumble and touch the endothelium or give jerk to the PC.
I feel that not only did it get hard, but I think it also got adherent to the sides of the cartridge because it didn't crack. Instead, it's the periphery that got sheared.
Yes. It was inappropriate size of the cartridge also.
Yes.
Was it a very high diopter lens?
No, no, no. It was a routine 22.5.
And did you put in viscoelastic at the tip of the cartridge also in the interior part? Apart from in the butterfly, did you
No,
put
no,
it
no.
also in the?
No.
Probably there also, if you would have put in, it would have probably helped in
Can we
lubricating the lens.
rewind the video and see where the actual margins are cut off? Is where the cartridge is actually holding onto those margins at that time when you're folding the lens. So this is probably also, as Dr. He has described, it's probably incompatibility of the cartridge to the lens. So good idea for all the newcomers and whoever start off with new lenses is to actually check the folding of the IOL after the cartridge has been loaded under the microscope before you inject the IOL, because that's where the entire problem happens.
While we are talking on the optics, these issues, sometimes it happens that the haptic of the IOL is stuck in the cartridge. Now, can you tell us
that is a
but here it is properly positioned. Can you see
not
this?
in this? No, no. This is all right. This is properly
folded.
Yeah.
But there was no visco in the anterior
part is what she's
no,
saying.
see, you see the anterior part here.
Yes.
Anterior part
Was
is
there
filled
visco
with
there?
the visco.
Isn't there? Okay.
One thing which I do once the IOL breaks inside.
Here itself, I could have
You can
stopped.
see it's broken actually, but
No, no, the distal part is broken, crushed. The proximal part was okay while injecting. Here itself, I was feeling the resistance too much. I would have abandoned at this stage only.
This is the incompatibility of the cartridge to the IOL.
Correct.
Okay. So if the trailing haptic is stuck, Swapna, can you tell us how best you would handle it and what could be the cause for that?
Well, there are two things to it. You have a 3-piece IOL. Sometimes the way you fold it may get the haptic caught, but it's rather easier to handle because it's a single haptic there. And that can, just with gently maneuvering the injector, you can use, you need to use an additional dialer on one side. You can maneuver it out. But if you're talking about a single piece IOL, something like this, where the haptic has got caught between the plunger and the base of the injector, then it may get pulled and there's a high possibility that may get torn off. So with one attempt or so, if it's not coming back, I would rather try to get it out than an implant.
Or maybe even make a small nick on that overlying cartridge and increase the space for it to get injected into the bag. We shall now, thank you very much, Dr. Sanjay. We shall now go on to
I wanted to make.
Yes.
One of the things I do additionally is once this lens is broken when we have injected it, I go ahead and bring it into the anterior chamber and then do an IOL scaffold. I put another IOL first and then
That's the idea.
cut and remove this IOL.
Yes. Correct. It's a very good suggestion. Makes sense. Thank you very much, Dr. Sanjay. Can you stop your video? We shall go on to our next speaker. Next speaker is Dr. Satyajit Sinha, who again needs no introduction, who's a chairman of the ABI Institute, Patna, and he's also member ARC East for the second round and quite a national figure. And he's going to show us a very good teaching video. On to you, Dr. Satyajit.
I would like to take this opportunity to thank Dr. Chitra Ramamurthy for giving me this opportunity. I'll be showing a video on posterior polar cataract, and each of the entries that we are making is very important when you are doing a posterior polar cataract. Even in this video, I have showed over here like I'm wriggling and going in, which is not the best way to be doing it. It should be a smooth entry in one go. There should be no leaky wound. You should fill the viscoelastic properly. And it's very important to make a good rhexis. And the rhexis also should be of such size that in case in future you need to do IOL capture, the rhexis should take the IOL for the IOL capture. But sometimes I make the rhexis a little bigger so that when these cataracts are soft, which they do not have any nucleus, just the cortex. So it is easier to remove, and there is less stress on the posterior capsule at the point where the PPC is. Then we slowly go ahead and do hydrodelineation, and before doing the hydrodelineation, we remove a little viscoelastic which is there in the anterior chamber. Once we have seen these golden rings, which you can see in this video, that gives you an idea that hydrodelineation is properly done. And then we shave off the cortex from, we start the phaco emulsification process. And slowly I use my second instrument also to move the nucleus which is there, so that we can turn it around and bring it into the phaco probe. Because the rhexis is a little bigger, it makes it easier for the nucleus to come into the for phaco emulsification. Now, once you have completed that, do not come out without filling the viscoelastic, because that will put some pressure on the point where the posterior polar cataract is. So the anterior chamber should be always fully stable. And then you go ahead and do this cortical removal. Even when I'm doing the cortical removal, you will see that I do not go all the way in removing the cortex until where the posterior polar cataract is. I only pull it and bring it to the point, to the central point, and then leave it, and then go to another quadrant to remove the cortex. Because I don't want the pressure to be happening at the point where the posterior polar cataract. Once the whole cortex has come in the center, already a lot of fluid is circulating in the bag, and that also helps in releasing the cortex from the posterior capsule. And then you finally slowly remove all the cortex which is there. And at all times, we have to make sure that we do not let the anterior chamber, we have to let the anterior chamber be as stable as possible. Once we have removed this, again, we have to chamber so that there's no this thing. And just like Dr. Sanjay was showing, even now, once you have finished that procedure, you still have to be very careful of how you are loading your IOL. Even when putting the IOL inside, there should be no sudden jerk, and it should be implanted smoothly because the posterior capsule at that point of posterior polar may be compromised. Right now, when we are putting these premium IOLs also in a posterior polar cataract that you have promised to the patient, the pressure is even more that nothing should happen. And even until you have completed the case of the posterior polar, even while doing the hydro for the cornea, there may be a posterior capsule rupture. Even when you are putting this IOL into the bag properly, you have to be very gentle and you have to make sure that the IOL is in the bag. The little cortical material that you are seeing on the posterior capsule behind the IOL, once you have finished removing the cortex, do not remove it at that time because the capsule is compromised over there. So now once you are removing the viscoelastic, this is the time that you can clean the posterior capsule and remove the remove the cortex that is there behind the IOL on the posterior capsule. So these are the points I wanted to share. And even when you are doing the hydrodissection, it has to be very gentle so that there's no pressure on the posterior capsule.
Thank you very much, Dr. Satyajit. That was a wonderful video with a lot of very essential tips across. For the panel, just for the sake of discussion, supposing you have done a good multifocal IOL in a polar cataract and the other eye, you've had a PCR during IA. Now, Dr. Chandrasekhar, how would you manage that particular case? How would you do that?
First of all, I would have counseled the patient that such a possibility always exists. And if I feel that the PC rent is not able to, I am not able to convert into a say, posterior rhexis, I would go ahead with a multi-piece IOL in the sulcus. If I can...
multi-piece multifocal?
3-piece multifocal is not easily available.
Yeah.
That is the problem. So that's why you unfortunately you have to go with a monofocal. But the best point is to convert into the tear into a proper rhexis. However, in posterior,
in a polar cataract, it gets difficult. It's a vertical slit.
Exactly, it is very easy, not very easy.
Yeah. We have access to, as of now, to 3-piece multifocal IOL. But supposing if we do come to a point when we do not have access, Dr. Ramurthy, what would you suggest? Would you try to make the patient a little myopic for the monofocal if that kind of a sitting were to happen? How would you deal with it? Would you want to give him better near vision, or would you want to give him distant vision?
No, it's definitely a compromise situation. And, we have to, if we don't have the 3-piece multifocal, we have to put a 3-piece monofocal in the sulcus and create an optic capture. And obviously, we have to explain to the patient the situation. It has happened to us, and we have even used a scleral fixation of a multifocal intraocular lens when we are forced to do this. And a couple of these patients have done well also. That's not something we'll recommend or talk from a podium, because even mild decentration, these lenses are very sensitive to it. But if I may make a comment on a very nice case, Satyajit, that you showed, just a couple of things and maybe just add-ons is that, once you have did a nice hydrodelineation and remove the nucleus out, in that case, I won't mind even doing a visco dissection, because once the capsular bag is opened up and there's no pressure on the posterior capsule, then sometimes removing the epinucleus and cortex becomes quite sticky. So doing a little bit of visco dissection mobilizes that and removes it more easily. And as you rightly pointed out, when there are small tags on the posterior capsule, unlike in other cases, you resist the temptation of polishing it, because that itself may make the posterior capsule give way. But what I do in these cases is, once the capsular bag is, before putting in the lens, I do a bit of hydro polishing. Just use a flush of saline on the surface of the posterior capsule. And if it's a fibrotic patch, it doesn't come away. But many of those small fibers and floating patches, is when you direct a flush of fluid there, it does come off and gives you a cleaner capsule. And then you can implant the lens.
Would you believe that in all posterior polar cataracts that we should definitely do an ASOCT to understand that how the posterior capsules, and that would be a very important investigation tool for polar cataracts. And based on this, if you see a polar cataract, would that mean that you would try to advise a cataract surgery earlier on to our patients? I think that has not yet happened, but should we think so that an earlier surgery would help? Is my thoughts to the expert panel.
ASOCT will definitely help.
No, earlier surgery for the polar cataract.
Earlier surgery also, it definitely helps, because the maneuvering is very simple.
Yes.
And you have to be
No, I won't agree with that. Definitely do a ASOCT that gives you an idea whether it's going to be more risky or whether it's a fibrotic patch and the posterior capsule is intact, in which case the chances of PCR occurring is less. And if it's open and you can see lens matter in the anterior vitreous, then obviously it's a pre-existing dent and you have to be prepared to deal with it. But sometimes you just see a small neck of a PPCC and the patient is quite comfortable. So in these cases, I think you should actually hold on. Why unnecessarily expose the patient to a risk of having a open PC and putting an intraocular lens in a compromised situation? So we wait for the patient to have a problem and then go ahead and do this. And most often PPC comes with fairly softish cataracts. You don't very often come up with hard cataract with the PPC.
Yeah.
So I would rather wait for the patient to start complaining about the vision drop rather than do an early surgery.
Yes, actually, I mean that only. That once the patient starts complaining,
then of course.
No point in, yes.
Yes. So thank you very much, Dr.
I want to take 1 minute. I want to thank Dr. Ramamurthy, sir. Afternoon after afternoon for all our webinars. Sir is always blessing us with his expert comments, and he takes out so much time for academic and research committee. Sir, we are very, very grateful to you for your time and all your comments that you give in our programs, every ARC program. Thank you so much, sir.
Thank
Yeah.
you, Satyajit. It's a pleasure.
That was nice of you, Satyajit. It is often getting difficult for me to keep him as an expert panel nowadays. Thank you.
So kind.
Yeah. So we shall now go on to our next speaker, Dr. Ronak Solanki, who's a chief ophthalmologist at the Neo Clarity Eye and Dental Care, Mumbai. And he's got another interesting video for us to see. On to you, Dr. Ronak.
Good evening, everyone. Thank you, Chitra ma'am, for this opportunity. I'll just like to present an interesting case scenario. Hi, this is a case of a 67-year-old female with a mature brown cataract, counting fingers 2 meters. She was on antidepressants and anti-anxiety medicine since 20 years. Was not willing for a surgery, but convinced very hard to undergo the procedure in only eye. Plan was to do a Toric SICS because it was a one-night patient. She was very anxious. We wanted to avoid multiple surgeries, so a quick in, quick out procedure with excellent visual outcomes was the key. Treating the patient and not the eye was the goal. The challenge was Toric IOL calculation. Precise SIA estimation, which unlike Phaco, depends on a lot of factors in SICS like wound size, shape, external and internal incisions, Toric IOL alignment and rotational stability, along with endothelial protection. Coming to the surgery, 0, 180 Toric marks were done. Coming to the calculation, you can see there's a pre-existing 2.04 diopters of astigmatism against the rule. During calculations, a planned SIA of 1 diopter was used and a IOL plane cylinder power of 4.5 giving a residual of 0.3 was used. We had multiple choices of IOL and finally an IOL which gave us 0.35 and 176 was used. Coming to the surgical steps, a conjunctival peritomy was done. Minimal cautery was used. 6 mm guide marks were used for the external incision. You can see them. A slightly larger incision than the marks, like around 7.58 mm was done as an external entry. Sclerocorneal tunnel was fashioned in the way. A meticulous dissection is the key because this is the most important step in the surgery determining your SIA. The internal lips were larger than the external lip. A trapezoid-shaped sclerocorneal tunnel was formed. A slightly anterior entry into the clear cornea is done, which will increase your SIA. Internal lip is extended using a 2.8 keratome. Final sclerocorneal tunnel of a 7.58 mm external incision and 8.5 to 9 mm internal incision is formed. Then a continuous curvilinear capsulorhexis is fashioned. It is a very important step that for getting a good overlap with the Toric IOL for rotational stability. An adequately sized CCC of around 5.5 to 6 mm is very important. The nucleus management is done with the help of Sinski hooks and an irrigating vectis, and the nucleus is delivered out of the wound. Bimanual irrigation aspiration is done to do a cortical cleanup and the polishing of the equatorial regions and the anterior capsular bag. A hydrophobic Toric IOL is placed in the bag and dialed into position using a dialer. Excess viscoelastics is removed from the bag with bimanual irrigation, and a final Toric IOL alignment is done before closing the case. You can see that the Toric IOL is well aligned with the 0-180 marks. Wound hydration, the conjunctival peritomy is closed using cautery. You can see that the final alignment of the IOL post-surgery. At post-op 3 months, you can see a well-aligned Toric IOL with good overlap of the CCC. You can see in the retro illumination a aligned Toric IOL. Post-op, note the new corneal astigmatism of -3.25 and a residual astigmatism of 0.5, which the patient does not accept and is an uncorrected visual acuity of 6.9. So the take-home points for a successful outcome in Toric SICS is precise SIA estimation, accurate Toric IOL calculations, a meticulous wound construction, Also, achieving spectacle independence is possible. The aim may not always be emmetropia. Reduction in the magnitude of astigmatism goes a long way in giving patients satisfaction and justify using them. Can also plan various EDOFs and multifocal IOLs. Thank you.
Thank you very much, Dr. Ronak. But how do you calculate SIA? You started off with 6 millimeter and it became a 7.5 millimeter incision.
So usually after doing so many cases, usually a normal SICS would be around 5.5 to 6 mm incision with an internal lip also around 6 mm.
Yeah.
Around the astigmatism which I'm analyzed is around 0.5 to 0.75. When I take a large, so then there's another one which I take is a larger 7.5 to 8 external and 8.5 to 9. These are the only two variations I make because all kinds of hard cataracts will come out through the 8.59. And I've over a few cases I've analyzed it that the SI is usually 1 to 1.25. So I've taken a planned incision of 8 mm and an internal lip of 8.5 to 9. And I've done this for 5 to 10 cases of my Toric IOLs in these hard cataracts, just to analyze, because I'm very confident of the SIA that is predictable. It may not be bang on, it could be just 1 or 1.25, 0.25, 0.5 variation. But as I said, with the pre-existing astigmatism of 2, the patient does not have anything to lose. As I said, the aim is not always to target emmetropia. If from 2 I can get him to 0.5, I think it's a fairly good enough job. This case, I had a Phaco, but the thing I usually would have Phaco, but this was a one-night patient and she was very anxious on antidepressants. She did not want to undergo primary surgery itself. So I just decided to do a safer approach and try out an SICS with a Toric IOL.
Supposing you had done an SICS, I think you're also, you did a very great job of your surgery. Supposing it had been a hard cataract, your excess would have had become larger. Then doing a Toric IOL with SICS is would not be unique at all.
This was a point. This was a brown cataract itself. So I've edited the part where I've tumbled it using a bimanual technique. So it's around 6 mm rexis. It's not a smaller rexis. It's a 5.5, 6 mm rexis. And mostly, if with a bimanual technique, they will tumble out usually.
Okay. Okay, right. That was nice. Any question to ask from the expert panel, or shall we go on to a last speaker?
Just say that superb surgery, very well documented and very well presented. I was wondering about the SIA, but you gave the answer that it's one diopter. Is it constant? Because some of your colleagues who do a lot of SICs claim that just by the incision, they are able to neutralize the pre-existent astigmatism. They can position, distance the screw incision. The screw incision behaves very differently from the corneal incisions. So any comments on that?
So usually sometimes when there is a with the rule Phaco which I have planned and patient is not affording a Toric and he has a 1.2, I just do a superior sclerocorneal incision like how I've done this, would probably be a larger sclerocorneal incision. It's mostly I felt that the anterior entry into the clear cornea which matters. Usually in conventional SIs we would take a 0.5 close to the blue-white limbus, but going more anterior and maybe 8.59, it gives a more predictable design. As I said, if you want to correct 1.5, you may just end up correcting 1. There's nothing to lose instead of doing a good Phaco and leaving 1.5 residual, because with a 2.2 or a 2.8, your centroid and SI would be just 0.2 correcting it, even if you do it on your steep axis.
Great.
Right.
Very good.
Thank you very much. So we shall go on to our last speaker, Dr. Viral Shah, who again is a senior consultant at Meenakshi Eye Hospital, Nagpur, and specialized in anterior segment and Phaco surgery, and more importantly, a very dynamic and a very popular person from Nagpur and for Vidarbha State Society. I do remember a very nice trip when I had come to Vidarbha conference and was so well received, and I look forward to watching Dr. Viral Shah's video.
Thank you, madam. At the outset, I would like to wish a happy Mother's Day to all the lovely ophthalmology ladies that are with us today afternoon. Thank you to Dr. Chitra madam for giving me this opportunity. Thank you to AIOS and ARC committee. So I will be speaking on hypermature cataract, suprahard with a milky fluid. The case profile in brief: a 78-year-old female was mild hypertensive, dense white hypermature cataract Vision was PR and PR accurate. IOP was 18 mm of Hg. Other I had a pseudophakia operated 10 years back in a camp, not my documentations. ECC was done. So whenever I see such cases, my preoperative pearl number 1, it starts with preoperative preparations. Cataract like this. So my SICS set gets autoclaved, my ECCA set gets autoclaved, my vitrectomy set is ready, my SFIOL is there, a 3-piece lens is there of the same power or the one diopter less, the iris claw lens is there, tricot is there, iris hooks, CTR, everything that I may need is ready before we take the patient into the OT. So I will play my video. Just, yeah. So as I mentioned, preoperative preparations is the first and foremost pearl from my side. Second is anesthesia. Always I give some 3 to 4 cc of peribulbar block because of anticipated increased time in surgeries, anticipated complications that may need more maneuvers that may be needed. This is a no-brainer. We always have to stay in such capsules where it's total white with some fibrotic strands seen in the anterior capsule. OVD always use some high whisk and dispersive and cohesive wicks like a soft shell technique when you also use. So always keep the AC formed. So I started the rhexis. Initially, I thought that it will be a simple case, but as I took rhexis for one quadrant, suddenly I hit a milky fluid pocket and the AC was flooded with milky fluid. So this is the step, pearl number 5, decompression. You have to aspirate this intralenticular fluid and put down the intralenticular pressure, and again you have to recompress the AC with viscoelastic and form the AC and flatten the anterior capsule before proceeding further. So this is pearl number 6 from my side, reforming the AC with OVD, flattening the anterior capsule. So again, we start with continue with our rhexis. Here you can go with either cystitome or you can enter the AC and use your rhexis forceps also. I decided to go ahead with my cystitome since I was able to see the rhexis margin clearly. A slightly lesser rhexis than I had planned for, but I was confident that I would be able to do Phaco from this, so I didn't enlarge it at this stage only. Gentle or minimal hydro procedures. Just a little hydro procedure can be done just to check about the nucleus, get a feel of the nucleus and whether there is any radiations or not. Now for Phaco nucleus management, you have to have appropriate parameters for Phaco. These are very hard brown cataracts. So we need a very high power with a low aspiration, slightly lower aspiration, so that you get a good hold on the nucleus to crack it. So try to crack it as much as possible in the bag. So I'm going able to get the first crack. So I proceed. Then it becomes a bit easier. So I divide the nucleus into 6-7 pieces inside the bag only. So after emulsifying most of the nucleus, managing the last nuclear fragment. This is the most important, one of the most important pearls. The last nuclear fragment, there is no epinuclear sheet there to protect you. So you have to be very careful. You have to do a slightly Phaco in a slow motion, or you can remove the other instrument from the side port so the AC gets deepened for a fraction. You can assess it better and then reintroduce that side port instrument and again form the emulsify the rest of the nucleus. So putting in the IOL and The last part is you have to stop and review as much as you want to do. Take your time, review the case at each step, and proceed further as per the case allows you. So that is the end of the case.
Wonderful video, Dr. Viraj, and really, truly excellent surgical skills shown. Only thing, maybe the rhexis could have been enlarged following the IOL implantation. I think I do not have any questions as to about the surgery as you have done it exactly the way it should be done. But supposing a person has a challenge in cracking the posterior plate, would there be any tips or tricks Dr. Chandrasekhar, Dr. Swapna would like to give? How would you all go about it? In those very leathery posterior cataracts, would you actually go and end up doing a stop and chop and breaking up into two halves?
Yeah, stop and chop.
Please.
Yes.
Stop and chop is one nice way to go. Yes. And I'd like to put in the instruments deep into the cleavage and separate them laterally way back at the posterior end. Yes. I mean, rather than, pull them open like that at the anterior portion, go down and separate, at the posterior end. So this reduces both the maneuvering, the amount of pressure you're putting on the zonules, as well as gives a full break. Now, in case you end up with a flower-like picture at the end of the day, then you can always flip that up and eat into the posterior part also, but that is more risky. So I prefer the first step.
Yes, Dr. Chandrasekhar, anything different?
Yes, shifting to stop and chop is definitely one thing on the mind. But before that, I would like to chop rather than taking a chopping and eating piece by piece. I would like to chop all of them first, because sometimes the chop does not extend right onto the other side, and then you can have a tilting of the nucleus. And sometimes you are left with a central disc. And if you get central disc, then the chop can be visualized directly, and you know that you are going in the right direction.
The best parameter to keep is to try to see the Phaco reflex, the reflex from the retro reflex, so that you know how deep you have gone and whether that's adequate to start the chop while you trench.
Yes, while talking on femto cataract in an intumescent cataract, I'm going to ask Anaga only to answer this question. What would be the challenge you would, how would you deal with it? What are the challenges you expect when you're doing femtosecond laser, LRCS?
Yeah, here many times what happens is, if there is a lot of milky fluid, the moment you start the femtosecond capsulotomy, because of the leakage of the fluid, there is a shallowing of the chamber. So the margin normally, which would be around 500, you can enlarge it to say 700 or 800, so that you have a good capsulotomy. But in spite of that, and many times the nuclear dissection is not really very good in case of white cataracts. So we should not expect too much of, even if you have done a softening, it may not really have helped. But always stain the capsule, even if it is a flax patient, number one. Secondly, expect that there will be some areas which have not been cut, in spite of us having seen, even though with the catalyst system, it's very fast, and before even the milky fluid can come out, you're done. But still, there could be some tags. So you need to stain it and see, and then very gently complete it if it's not cut completely.
So Anaga believes in increasing the offset which is from 300 up to 300 down. So Swapna, would you also want to increase the offset? Ramurthy, would you also look at increasing the offset? Because it makes logical sense.
Yeah, because there are a lot of undulations in the capsule. So yeah, that makes sense.
Yeah.
I personally don't do that. I mean, both the lenses as well as the this catalyst platforms and even other LENSAR and other things all work on the principle of contour guided capsulotomy. So basically the OCT itself recognizes where exactly the capsule is. So even if it's slight tilt is there, obviously if subluxated, it's different, but otherwise it compensates for those undulations. And when you make a standard 300 micron offset, both anterior and posterior to the capsule, anterior capsule, then usually get an adequate rhexis. Of course, as Anaga said, you can get a postage stamp. It's not always a free-floating rhexis. It's a good idea to stain and separate it. And it is the same reason that even when it's a PPC, I don't increase my offset from 800 microns to 500 microns, 500 to 800 microns, because the OCT takes care of it and doesn't really touch the posterior capsule.
So the point was that it's not a dynamic OCT, and as the fluid escapes, the level of the capsule changes. So to cover for that change in level is what I think.
Yeah, that's what I also meant.
There are 3 questions which have come up, and there are some more, but anyway, I just rapidly, we just 2 minutes, we'll answer this. Would reverse optic capture of a square edge lens produce iris chafing and pigment release?
That's always a compromise in the sense, any square edge, whether it's in the haptics or the optics, if it is in the sulcus, it's not a good idea. So it is a compromise.
And sudden constriction of pupil during hydrodissection in a planned phaco. What all could be the reason and how to go about it? One could be the constriction, could be the pupillary snap sign, which is what he means. Or this could also be something like, you see in a high myope, there could be because of the elasticity of the sclera, and there could be a sudden meiosis of the pupil.
Oh, no.
And,
iris retropulsion syndrome, you get a dilatation. You don't get constriction.
You get a dilatation, yes. Yeah. So what else could be a reason? Anything which strikes to your mind which we could answer this young doctor?
No.
Direction of fluid, bringing the iris, causing the iris to bellow up or something?
No, it's basically bellows up, then it would dilate, because it's the loss of the stretch that causes it to constrict. That's the reason that
this is something which happens in a high myope. Sorry? I think this is some characteristic thing which could happen in a high myope, that sudden pupillary meiosis and dilatation for which
in a high myope, it happens, ma'am, when you put fluid under the iris, that is when it constricts. But in a high myope, during retropulsion, the anterior chamber deepens, the iris lens diaphragm moves backwards, and the pupil dilates. But if you put your fluid under the iris, then it would come up and constrict.
Yes.
So
that could be probably one other reason for the meiosis. I couldn't think of any other answer. And of course, the other question is anterior capsular tear, how to proceed further. I think one has to be just do a very careful, if you're going to do, either you are a beginner surgeon, you should convert at that point, or if you are a careful surgeon, I suppose you would have to look at the extension of the tear, whether it's everted or inverted, and looking at that, do a careful phaco, directing your phaco forces away from the area of the tear, and keep in view that the tear does not extend. And if possible, you could even bring the pieces supracapsular and go ahead and complete the case. And when you plant the lens, it should be away from the direction of the tear. Anything else we have missed out which you all want to answer for this?
Always inject viscoelastic before removing the irrigation.
Yes.
So that it doesn't extend posteriorly.
Yes.
And Dr. Rohit Omprakash has explained very well that a flutter of the anterior capsule, that when the tear has gone to the posterior capsule, there is no flutter. But as long as it is fluttering, it means that it is still not reached the posterior capsule. And that's a very, very important
the direction of the flutter. If it is upwards, then and downwards.
Just stop. Upwards is safer. When it becomes inverted, it means it has gone back. Wraparound rhexis, wraparound tear. So I think it has been a very exhaustive 3 hours, and I truly believe that if not for this amazing expert panel, we could not have gone through very well. And I'm truly thankful with the speakers also this time for their very energetic contribution during the course of the meeting. And I'm truly thankful to one and all of you, the top class expert panel, and with their answers and the very great set of speakers. Very interesting videos, such variety of topics which are covered. I'm sure all of you enjoyed these 3 hours as much as I enjoyed it. And I think we need to definitely thanks to Anagha for being the constant, stable moderator whom I knew would always come out with a question in case I falter anywhere. And thanks a lot to my ARC team and Satyajit for being a superb talk which he gave, and of course always being a major support for me. And so are the other ARC people who incidentally are not there at this point of time. And I think we need to thank the AIOS admin team and Mr. Kripal for sending those prompt SMSs, and of course Sai and Manjula from Numerotech for all those amazing, amazing, the way they crowd your mailbox at all time. I think today morning there were 3 mailers from me, if any of you did see the mails. And I wish to hear a good comment from you all about our interesting ARC video which I had shown. I would be very obliged if you all have something favorable to say. I don't know how many of you saw that ARC video which I had sent on the email. If you have not seen it, please go back and see it and send an encouraging comment so that we do even better in the next 1 year which is left for us. And finally, I think, of course, very deep felt thanks to Entod for being those great sponsors for all our programs. And finally, and most importantly, I think we need to thank attendees. It's their presence and it's their numbers which encourages us to keep coming back to you all with more and more webinars. Thank you very much, one and all of you. Thank you.
Thank you. Thank you.
Thank you, everyone. Thank you, ma'am.
Thank you, all of you. Thanks, Dr. Abhijit, Dr. Asal, Shail, all of you.
Thank you, madam. Thank you.
Thank you. Anand Sethi, thank you very much.
Yes. Anand Sethi, oh my God. Dr. Anand Sethi, so sorry I missed you out. Thank you so much for being such a major support at all times. Thank you. Thank you so much.
Thank you, ma'am. Bye-bye.